Subsequently, his symptoms gradually increasing, and he was referred to Guwahati Medical College, the Department of Pulmonary Medicine. He attended Pulmonary Medicine's OPD. In the OPDs, we examined him, and he is thin build. On examinations, there is pallor and bilateral pitting edema. On chest examinations, there is tachypnea and bilateral basal capitation, and cardiovascular examinations, there are loud P2 and pansystolic murmur in tricuspid area. On chest X-ray was done in the Silsor, it 1 month back. It shows multiple round opacities in both lung field. And 1 month back, chest X-ray was repeated in our OPD. You also increase opacities. And the bilateral round opacity is also increases. It is called cannonball opacities. And these increased opacities may be due to alveolar hemorrhage, or there may be secondary infections. So what may be the differential diagnosis of those cannonball opacities? There may be long list of differential diagnosis. It may be metastatic, like from sarcoma, seminoma, Korean carcinoma, colonic, prostatic, thyroid, breast carcinoma, renal cell carcinoma, and squamous carcinoma of the lung. And it may be due to infections like septic emboli, multiple abscess, tuberculosis, nocardiasis, histoplasmosis, coccyomycosis, and histoplasmosis. Or it may be due to immunological cause like Wegener's granulomatosis or rheumatoid nodules, which is called Kaplan syndrome. Or it may be due to vascular origins like arteriovenous malformations or aneurysm. Those are a long list of differential diagnoses of cannonball opacities in the lung. So on investigations, there is anemic. Total count is also increases. ESR CRP is elevated. D-dimer or is 2.4. It is elevated. And other antinuclear antibody, rheumatoid factors, and other rheumatoid profile is negative. And vascular leads profile like C-ANCA and P-ANCA and anti-cardiolipin antibody is also negative. To exclude secondary, we done ultrasounds of the scrotum and thyroid, and abdominal ultrasound, CCT abdomen was done. There is a moderate ascites, no abdominal lymphadenopathy, and no mass is seen. Bronchoscopy was done. There is no endobronchial pathology, and lavage fluids, GSCS, AB, and malignant cytology is also negative. Then color Doppler of upper and lower limb also does not reveal any pathology. Then echocardiography is done. Echocardiography shows that there is thrombus in the right atrium with dilated RA, RB, and moderate TR and moderate pulmonary arterial hypertension. Then pulmonary angiography was done. Pulmonary angiography showed that right ventricular type of cardiomegaly, right atrial dilatation, right atrial and inferior vena cava thrombosis. And there is multiple dilatations of the aneurysmal dilatations of the main pulmonary arteries. So what may be the diagnosis? Pulmonary aneurysm in the pulmonary artery with IVC thrombus, with thrombus in the right atrium, and recurrent episodes of hemoptysis. This final diagnosis is Hughes-Covin syndrome. It is a very, very rare disease. It is characterized by multiple pulmonary arterial aneurysm and deep vein thrombosis. In our patients, there is no deep vein thrombosis, but he has thrombus in the IVC and right atrium. It is a rare disorder of unknown etiology. Less than 40 published cases in English medical literature. About 25% of patients with Hughes-Covin syndromes develop thrombosis, arterial aneurysms, and vascular occlusions. Then intercardiac thrombosis is very rare presentations. It is presumed to be a cardiovascular variant of Behçet's disease, occur in the young adult, mainly at the age of 12 to 48 years. So there are 3 stages of the disease. First stage, there is thrombophlebitis. Second stage, there is aneurysmal formation. And third stage, the fatal stage is the aneurysmal ruptures, leading to hemoptysis and leading to death. So, there is no standard treatment, but promising treatment is combinations of glucocorticoid and cyclophosphamide. In our patients, we give pulse cyclophosphamide and glucocorticoid. We give about 4 to 5 pulses. The use of anticoagulation is controversial. The risk of fatal hemoptysis is there, allowed only in selected cases along with immunosuppression therapy. Other possible treatment include surgical resections and arterial embolization, but in huge generalized involvement of the both lung, resection is not possible and arterial embolization is also not possible. So this is the very rare cases presenting with recurrent episodes of hemoptysis. So my second cases is patients with recurrent episodes of wheezing. If one patient comes with wheezing, usually we think bronchial asthma, chronic obstructive airway disease, pulmonary vascular Sasto syndrome, bronchiectasis, eosinophilic pneumonia, and episodic variant of ILD. Usually we think of those diseases, but some rare disease can also present as a recurrent episodes of wheezing. Here in cases is 54 years male from Lower Assam complaining of cough for 5 years, shortness about 5 years, and wheezing for last 5 years, and occasional hemoptysis since 2 years. This cough is persistent, minimally sputum productions, no diurnal and seasonal variation. Shortness of breath is persistent, progressive. There is no associated with wheezing and not associated with orthopnea, PND, and pedal edema. Persistent wheeze for last 5 years, more at night, and it may occur mainly in expiratory phases. Hemoptysis for 2 years, which is blood-stained sputum. And history of multiple hospitalizations in the past for similar illness. History of ATT intakes for 9 months in 2021 on the clinical radiological basis. He has been used MDI for last 5 years. It's a not known cases of diabetes mellitus, systemic hypertension, and thyroid disorders. On examinations, there is BMI is 32. There is mild pallor and bilateral clubbing is there. Other is normal. And what may be the possible causes of recurrent wheezing of these patients? He has history and clinical examinations. It is a airway diseases, means disease involved in the airway. And shortness of breath, wheezing, hemoptysis on examination, bilateral rhonchi for last 5 years. Those are the possibilities. It may be bronchial asthma, it may be COPD, bronchiectasis, or vasculitis syndrome. So we think those 5 diseases. On investigations, there is hemoglobin is 8 grams. Other parameters is also normal. Hilar opacities. On CT scan, it shows that there is multiple nodule into the airway, this trachea, and in the two major airway, right and left airway, with thickening of the air wall. Airway thickening and nodularity mainly found in tracheobronchial papillomatosis, post-infective tracheobronchitis, sarcoidosis, granulomatous polyangiitis, which is called Wegener's granulomatosis or amyloidosis. In those cases, we may get nodular infiltration, swelling, and thickening of the airways. Then bronchoscopy was done in our department. This trachea is diffuse mucosal nodule narrowing of the trachea lumen. Then there is widening of the carina, and right and left bronchial diffuse mucosal nodular thickening seen in entire right and left bronchial causing narrowing of the lumen. That is erythematous mucus seen. So differential from this finding, Diagnosis may be granulomatous polyangiitis, sarcoidosis, and amyloidosis. Histopathological examination was done. They shown subepithelial tissue show depositions of the abundant extracellular amorphous eosinophilic materials, and Congo SS is also positive. So it is diagnosis is tracheobronchial amyloidosis. Again, amyloidosis is a disease associated with abnormal extracellular depositions of autologous protein causing organ dysfunctions. Tracheobronchial amyloidosis is a very rare disorder. It's only a few hundred published cases is there in English literature. The diagnosis of respiratory amyloidosis is challenging and often missed since this clinical symptom is non-specific. Treatment options is anti-cancer drugs can be given. Then some targeted therapy is Petistian and Inotestan and stem cells therapy can be started. Long-term prognosis is not good in tracheobronchial amyloidosis. Only treatment focus is focused radiations like brachytherapy or stereostatic therapy or bronchoscopic guided debridement and ablations of the amyloid gout. Our patients there is no complete obstruction, so bronchoscopic guided debridement ablations is not required now. We start cyclophosphamide pulse in these patients, but he is not responding. Although we give 3 pulses of cyclophosphamide in this patient. Thank you.
Thank you, Dr. Hazarika, for 2 excellent cases. I am sure the audience will definitely having a lot of questions. We'll take up the questions the last part of the session. I also thank him of finishing exactly dot on time. Thank you, Bokhanto. Keep on alert. You'll have a lot of questions at the end of the session. Thank you. I hand over the mic to Dr. Anand Goswami for the next proceeding.
Thank you. Our next speaker is Gunojit Das. He will speak on litigation in clinical practice, how to avoid. Dr. Gunojit Das, please. Oh. Here I would like to tell our speakers that they should restrict their time limit, and time limit is 15 minutes, and before ending of, at 13 minutes you will get a warning call, and after that within 2 minutes you are to complete your talk, because organizers are very strict on this time limit, so we have to remind you again. Thank you.
Good morning, everyone. With my sincere thanks to the organizer and API Tezpur branch for giving me this opportunity to be on this prestigious platform. I just start with the disclaimer that we are not going to instill any fear in the minds of anybody sitting out here. We're just trying to keep ourselves prepared for facing the litigation. It's not about avoiding litigation, it's about preparedness to face litigation, because every patient, whenever they visit us, is a potential litigator. At any moment or time, he can become a litigator. Now, coming to the actual topic, just I start with this picture, which depicts one chaotic situation to which we are almost familiar. Wherever we go, we see this. And when we say something about litigation, litigation is something like driving a car in such a situation and reach the destination. When we go in such kind of situation, the first choice should be a proper vehicle that needs to be chosen. But before that, what we need is the driving license. Law never think as from where I have learned the driving, but it wants that the person is authorized to drive. Say I am a MBBS graduate or MD, where from I have acquired the degree that is not material, but whether the regulatory authority has permitted me to treat patients, that is more important. At the same time, there must be a destination, and destination is nothing but the treatment procedure or surgical intervention that we propose for a particular patient. And for that, driving the car, someone must give me consent to start the engine, so ignition should continue till reaching the destination. The consent should be in a proper way. there should be adequate engine oil and petrol or fuel, and there should be represented by the adequate documentation that we are supposed to make right from the beginning till the end, till I reach the destination. Next is GPS. I should have a proper connection with communication so that I communicate if there is a change in the treatment process or change in the destination or change in the road which I choose to go, and that there should be a communication on either way, and that should continue till reaching the destination. And the most important part is I should know at what point I should push the brake. That means at what point I am supposed to stop. And if something happens during my journey, and if something breakdown happens to my car, there should be someone who comes to bail me out. And that's why having a coordination and cooperation with my colleagues as well as my peers is the prime important factor in maintaining it. Now coming to the actual practice regarding dealing with patients, there are certain ways in which we formulate our function. Either we go by traditional way, either we go by conventional way, or sometimes where conventional means doesn't remain, we go for arbitrarily, we just decide that, okay, let's do it like that. But there is tremendous judicial intervention in recent times, and we have various judgments which specifically decide as to how a medical professional should function in different areas. Let's see some of the I have just selected some of the very important judicial judgments which gives us idea about the function in which we should work. Attending to an injured person, everybody sitting out here, they know about the Paramananda Katara, where we are supposed to give the treatment in emergency situation, whether we are working in a private setup or corporate setup or government setup. Then vicarious liability of government hospital. Previously it was thought that the government hospital, the vicarious liability is not there, or superintendent or principal of the particular college will not be responsible. Some wrongdoing by a subordinate staff, automatically the vicarious liability will come as per this particular judgment. Then prosecution of Dr. Jacob Matthew case is very famous. Everybody in medical profession, they know about it. And nobody can come just and in a allegation of negligence, somebody will come and a police official will come and take the medical officer to the police station or interrogate or something. So there is a proper procedure mentioned in this. One particular way, whenever there is a medical negligence allegation, we become very panic and we start doing some manipulation or just making the ticket very as per the norms. And we change, or there is a tendency of changing the ticket or making the ticket in a proper way, thereby writing something, editing something, or deleting something. That change in handwriting and ink is also taken as some amount of fabrication in the ticket. Then responsibilities of doctor as to how I am supposed to work with the patient, in what way I am supposed to give the service, what are the things that I need to look for. That is under the PV Desai judgment. The most famous judgment where the maximum amount of compensation was given was the Anuradha Saha and Kunal Saha judgment, where the contributory negligence was not documented, whereas Biskendi Hospital documented, so Biskendi Hospital was exonerated, whereas AMRI Hospital was not exonerated because they presented that there was contributory negligence, but they did not document the same. And the consent part, which is known for everybody out here, is governed by this particular judgment. Now, whenever we discuss something about defending litigation, there are three pillars. Number one is the consent, second one is the communication, third one is the documentation. And knowledge is seldom challenged, but we are supposed to follow the procedural norms which are suggested by judicial judgment as well as administrative authorities. Now coming to the consent part, this is only one judgment which specifically says about as to how the consent should be taken and what should be the content of the consent form. There are hospital consultancy services, there are corporate hospitals who have the different forms. It may be 10 pages, 20 pages or 30 pages, but if these points are not there, that consent will not be valid. And one point we usually miss, we ask for the consent and then these patients will discuss with their friends, their own doctor, and there will be certain amount of delay in giving the consent. Say we have asked for it and then either consent refused or given, there is a time lag, and if there is a change in the patient condition, there is a chance of litigation, and that's why putting the time at which we explained everything and at what point the consent was refused or the consent was given, that needs to be added or documented in the document itself or the ticket itself. And what should be the content of the consent form, it was specifically mentioned in the judgment about giving adequate information. And that adequate information is specifically defined by these 4 points: that nature and procedure of treatment and its purpose, benefit and effects, alternatives if any available, an outline of substantial risk and adverse consequences of refusing treatment. And when we go for consent, the first thing we have to go for the competence of the particular person, mentally sound, the particular age group, the disclosure should be absolutely full. There should be proper understanding of what I have explained to my patient. I should be convinced that the patient has understood. Voluntariness should be there from the side of the patient. No one is forcing him or no one is requesting him to give consent. And lastly, he will consent and we shall proceed with the driving. Next one is the communication, where it should be empathetic. I need to feel the pain of the patient, but I'm not supposed to cry with the patient. Otherwise, I'm not going to, I shall not be able to give proper service to the patient. There should not be a boundary violation. We should be absolutely professional. It's not about just praising somebody, someone's wearing garments or earrings or something like that. This is not within the purview of our professional service. We should stick to what I am supposed to talk to the patient and what kind of information I need from the patient. And lastly, there should be a proper transparency as to the treatment plan as well as other aspects which are required. And there must be an avoidance of medical arrogance and not taking time to explain. There should be a proper explanation of whatever we are planning. Again, behind every litigation, there is one patient. Either he is injured, either mentally or physically, or he is angry. Because of 2 reasons, either there may be technical error in the treatment process or somewhere he have found, or patient-doctor relationship is strained where he is unable to express what he wants to express. Or there may be competence issues. Say I have exposed or I have proposed or I have say projected myself to be a truck driver and actually he has come to know that I only know how to drive a 2-wheeler. So that should not be there. And there should be a proper communication in between the patient as well as the other aspects. Now coming to the documentation part, whenever we go to any hospital, we get many kinds of papers need to be filled up both by the doctor as well as the attendants, and these papers are usually prepared at the beginning of the hospital. And sometimes, even from my personal experience, I have seen that few of the corporate hospitals, they have made many papers, but the points which are mentioned in 3 specific statutory documents of the Government of India, those points are missing. If those points are missing, whatever may be the volume of the papers which we maintain against the patient, those become invalid, and it becomes very difficult to defend ourselves that we documented everything while giving the treatment. What are those documents? First one is the Hospital Manual 2002. It specifically mentions about maintaining the hospital ticket, the content of the hospital ticket, the papers, in what way the temperature chart should be maintained, the diagnosis should be written, in which page, and what is the sequence of the different papers to be kept in a particular ticket. Next one is the etiquette regulation, and the last one is the most important one, is the medical records manual, which is referred by almost all the courts while dealing with negligence cases, because we have to check whether those points which are there in the medical records manual are incorporated in the particular papers which are maintained in a hospital, whether it be it a private hospital, corporate hospital, or government hospital. And that's why knowing details about the medical records manual published by the WHO is a prime importance while dealing with any kind of patient. And lastly, in the document section, one important part is there, that is the record retention schedule, which specifically says about one thing which we usually ignore. There cannot be a fashionable ink while writing or putting our signature or while writing the medical documents. Only 2 colors are allowed, one is blue and one is black. There cannot be a yellow color, there cannot be green color or something, some fluorescent color while putting our signature in a document which are likely to be produced in court if there is a litigation. Now, if we follow all these, I feel we shall remain prepared to face any kind of litigation which may come during our practice. Now coming to one particular sentence which we see in many of the prescription, there should not be any self-styled statement like not valid for medical legal purpose, because we cannot dictate or direct the court which paper should be accepted and which paper should not be accepted. It is the court to decide which will be accepted, which will not be accepted. And writing this line specifically divides our care into two different categories, because I have seen few evidentially document where it is said by the particular physician that it was not brought by police. Whether the case is brought by police or not brought by police, there is always a chance of potential litigation from any patient. And it is not that at the time of arrival the patient was medical legal or a police case. It may become a police case even after discharge. And it is not that a natural death case cannot become, or natural disease case cannot become a potential litigation. There is every possibility of litigation with each and every case, and that's why we need to remain prepared and avoid any kind of self-styled statement. Now, coming to the concluding remark, there are certain risk reduction strategies which we already have discussed under this three heading. First one is the competence. I had to be very competent in the field where I am practicing. There should be a proper communication with the patient as well as all other authorities. If I am bound to inform some authorities, definitely I have to inform. Next is the consent. Until and unless I get the proper consent, I'm not supposed to start. And once I get the consent, careful prescribing should be there and proper documentation of what I prescribe. And whatever I prescribe or whatever I do with the patient, that should be recorded properly in clinical records. And during the entire journey, right from the beginning till the patient is discharged or dead, because there may be two outcomes, either discharge or death, whatever may be the outcome, that there should be a constant vigilance during the treatment process and the patient confidentiality, because there are certain diseases where I'm bound to disclose it, but disclosure should be to designed authorities only, not to anybody else. Because that is a statutory requirement, and under that statutory requirement only I am supposed to disclose. It's not that I'm just keep on going disclosing it to anybody else. So I have to be very particular while disclosing, or otherwise I have to know very particularly the confidentiality criteria. And under this is the concluding remark. And these are some of my references, and specifically those court judgments which dictate us for doing the medical practice in a proper way. And I just have a humble suggestion before the Honorable House that if we go through those 5 or 6 judgments, the explanation and the description of the conditions and the conclusion which are drawn by the Honorable Courts, that gives us a good idea as to how we are supposed to practice. Thank you.
Thank you, Dr. Das, for your very nice talk. Our discussion regarding your talk will be taken up at the end of the session. So thank you very much. I hand over the mic to Dr. Sharma to call our next speaker.
Next speaker is Dr. Greenwood Gogoi, Professor, Head of the Department of Medicine, Assam Medical College. He is my classmate, and we are all 1967 batch of Assam Medical College. I request Dr. Gogoi to continue his speech.
Respected chairpersons, honorable members of the API Assam State Chapter, honorable members of the organizing committee, ladies and gentlemen present. Today I am assigned to talk on the very simple and basic subject, that is examination of the hand, its clinical significance. Probably to preserve the tender task in the digital area. So, hand is the one of the most complex structure of human body. But a simple examination of this complex structure can give us a lot of clue to our clinical diagnosis. As a physician, we start examining the patient as soon as the patient stands in the door of our chamber. We observe his stance, we observe his gait, we observe facial expression and his behavior towards the environment. Some of these patients may come with a folded hand offering us namaskar. While we reciprocate, but at the same time, as a physician, we are interested whether his fingers are in proper position or not. If the fingers are in proper position, then it is normal. If not, it can be a mild in a position, or it can be a severe like this one. Is it a cheirorthopathy of long-standing diabetes mellitus? We ask the patient to place the hand in the tabletop and see whether his fingers can remain flat in the table, or he fails to do that one. And this confirms that the patient is suffering from cheirorthopathy as a complication of the long-standing diabetes mellitus. This tabletop test can also be performed in patients with Dupuytren's contracture. Some of the patients may come with an introductory handshake. While doing the handshake, we observe whether his hands are moist and cool, suggesting that he is having anxiety neurosis. Moist and warm, may be having thyrotoxicosis, and failure to relax the grip or inability to let go. Then immediately you look for the forehead. If it is bald-headed, it can be dystrophia myotonica. If not, it can be myotonia congenita. We immediately tap over the muscle and see whether there is pitting or not. If there is pitting, it is likely to suffer from myotonia. Then the grips may not be sustained and it is irregular like a milkmaid's grip, and it indicates that person is suffering from chorea. Then to examine the hand proper, let us begin from the dorsum of the hand. The color may be black. When the color is black, then the other parts of the body, we immediately look at the face. If the face is emaciated, it can be Addison's disease, or it can be a case of chronic liver disease. But if the face is moon face, then you must think of ectopic HCTS syndrome. If the hand is red and tender, it can be infective in origin. And if the color is blue, immediately warm it by rubbing, and if the blueness disappears, it is peripheral cyanosis. If it persists, it can be central cyanosis, and if there is slight change, then it can be mixed cyanosis. If there is yellow, immediately you look at the eyes. If the eyes are also yellow, it is jaundice. If the eyes are not yellow, only the skin is yellow, it can be a case of hyperkeratinemia. Then you see the skin condition, it can be shiny, stiff, and difficult to pinch. It can be a case of scleroderma. And then we will go for the joints. And metacarpophalangeal joints, proximal interphalangeal joints, inflamed and swollen. It can be rheumatoid arthritis. Only the proximal interphalangeal joints, especially to start with the ring finger, it can be SLE. Then we get the various deformities of the rheumatoid arthritis, swan neck deformity, bottom ear deformity, ulnar deviation, etc. And then we go for looking at the dorsum of the proximal and distal interphalangeal joint, we get nodules in the proximal joint, the Bossard node, and then Heberden's node in the distal interphalangeal joints, and both suggest osteoarthritis. Then we see the condition of the fingers. It can be long, thin, slender fingers, maybe arachnodactyly or spider fingers. It can be a normal variant, but it can be a case of Marfan syndrome. If the skin is too much elastic, it can be Ehlers-Danlos syndrome. And there can be syndactyly or polydactyly. Both may be associated with atrial septal defect. And the fingers can be big and coarse in comparison to the normal, and then it can be a growth hormone excess or pituitary adenoma. So then we go for to look for the nail changes, and the proximal portion majority is the white, and only a thin rim of a dark brown strip in the distal end of the nail is called Terry's nail. It is found in cirrhosis of liver, type 2 diabetes mellitus, and in advancing age. Then if the 50% of the proximal half is white and distal is brown, it can be Lindsay's nail or half and half nail. It can be a case of CKD. Then also look for the Bu's line. These are because of some catastrophic illness that arrests the nail growth, and then when the catastrophic illness is over, nail starts growing again and giving a transverse groove. Distance from the base to the groove indicates the approximate time when he or she suffered from this illness. Then we can see the white transverse line, which is called Mees line. It can be single or it can be multiple. Usually we get in the case of arsenic poisoning, sometimes in malignancies like lymphoma, and it may be because of the chemotherapy with doxorubicin, vincristine, or cyclophosphamide. The differential diagnosis of Mees line is the Marquez line, where it is also the white line, but the changes there is in the vascular bed, therefore it blanches in pressure and it will not grow along with the growth of the nail, like that of Mees line. So there can be a black splinter hemorrhage in the distal end of the nail. Mostly it is because of the trauma, or most important medical disease is the subacute bacterial endocarditis. Then we can also get the pitting nails in psoriasis, connective tissue disorders like Reiter syndrome, autoimmune disorders like alopecia areata, sometimes in sarcoidosis. And in the Quitter's nail, there is a nicotine stain in the distally. When a patient stops smoking or changes to low-tar tobacco, the proximal portion becomes white. Then there can be koilonychia and platonychia, more common in the toenails, but sometimes in the fingernails also we get it. It is in the iron deficiency anemia, but sometimes in severe heart disease and hypothyroidism we can also get koilonychia. Then in the clubbing we see the onychodermal angule is lost, and then you know the causes in the respiratory, cardiac, GI, and other miscellaneous causes. Then some miscellaneous findings in the nail. Blue lunula is in the Wilson's disease. Then the longitudinal melanonychia in vitamin B12 deficiency, it may be a normal finding in dark skinned people, and most serious one is the subungual melanoma. And then we can see the capillary pulsation in the tip of the nails, increased pulsation we get in the aortic excitation. And then we come to the palmar surface. start with the tip of the fingers. And these are the fingerprints method of identification. Mostly these are the loops or holes and arches. Although these are the methods for identification, but as a clinician, we are interested in the holes because there is increased incidence of hypertension in persons having the holes. More is the number of holes, more is the hypertension. So then there can be ulceration in the tip of the fingers, suggesting vasculitis. There can be a small distal phalanx. You inquire about the Raynaud's phenomena, and it is a findings of the scleroderma. Then in the tip of the finger, we also see the capillary refilling time. You press the tip of the finger and see the blanching and what time it takes to recover the blanching. And normally it is 1 to 2 seconds. If it is more than 2 seconds, then it indicates peripheral circulatory failure. And then in the tip of the fingers, there can be tender, red, palpable nodules. We call it the Osler's node, maybe in the subacute bacterial endocarditis. And sometime, and then you go to the palm. It is a red palm, maybe primary, without any cause, and then secondary due to some causes like cirrhosis, estrogen excess like pregnancy, thyrotoxicosis, Wilson disease, Kawasaki disease, alcoholism, etc. Then you look for the Dupuytren's contracture. There is thickening of the tissue of the palm, and it may be a cord-like structure. It may pull the 1 or 2 fingers towards the palmar surface. And then we go for to observe the palmar creases. There can be hypopigmentation because of the chronic anemia. There can be hyperpigmentation in hyperpigmentary diseases like liver disease, and then sometimes there can be single crease with short fingers in Down syndrome. Then in contrast to that Osler's node, Janeua lesions are non-tender, non-palpable, and it is because of the septic emboli found in the bacterial endocarditis. Then we examine the muscle for worsening of the thenar and hypothenar eminence because of the ulnar median nerve lesions. It can be global with diminished jerks, C8 to T1 root lesions, or it can be a global wasting with increased jerks, amyotrophic lateral sclerosis. And then we go for the ulnar palsy. We do the book test and see the adductor pollicis is paralyzed because of the ulnar lesions. So flexor pollicis will take the upper hand, which is supplied by the median nerve. And then we go do the different sensory examinations in the ulnar nerve distribution, median nerve distribution, and radial nerve distribution. So we see also look for the tremor. It can be action tremor in the outstretched hand as in case of thyrotoxicosis, tremor at rest as in case of Parkinsonism, intention tremor as in case of cerebellar diseases, and flapping tremor in mostly in 3 failures, renal failure, respiratory failure, and most importantly, the hepatic failure. Thus, findings in the hand leads to clinical diagnosis of almost all systems of our body, and examination of the hand helps in confidence building with the patients. Therefore, I always request all of us should make a habit of hand examination. Thank you very much.
Thank you, Dr. Gogoi, for your nice presentation. Now, I hand over mic.
Good morning, everybody. Now I think we should proceed for the part of discussion. The 10 minutes is allowed for discussion, so please. Yeah.
Three questions.
Only 3 questions. Okay.
I congratulate all the three speakers for the excellent deliberation. One question to Dr. Gunojit Das. His presentation was very nice. So one frequent problem we used to face is, when patients and attendants, they ask for discharge on request and discharge against medical advice. In this situation, what is your advice? And when a patient, a celebrity patient is admitted in a hospital, so the question of confidentiality comes, and a lot of media people comes and asks us about the patient's condition. So this is one actually difficult situation. So what is your advice in these two particular conditions?
Now, regarding the first question, discharge on request and discharge against medical advice. Now, in commonly known as LAMA, one thing is there that there cannot be a discharge against medical advice. The doctor has a right to choose the patient also has the right to choose the particular doctor. Now, for me, against medical advice or medical advice, that's a different issue. But as the patient has the right to choose the doctor, we can discharge on request, but at the same time, it is also our responsibility to give in details whatever treatment has been followed in my hospital, so that the second doctor whom he approached, that particular second doctor comes to know what kind of treatment has been given to that patient, and he can continue with that. And next point is, whenever we discharge, in few of the hospitals, what I have seen personally, the discharge certificate is not given, it is given in a different form. The patient has the right to get the discharge certificate in all types of cases, because as I have said that there are two outcomes, either death or discharge. If death, the question is different. If discharge, he is discharged with medical advice or he is discharged on request. Against medical advice, if I know that it is against medical advice, why should I discharge? When I say against medical advice, whether the patient attendant actually requested us or not, that is not mentioned in the discharge certificate itself, and that becomes a big problem later on. The attendant can later on say that we did not request, but the doctor discharged against medical advice. So that's what is the need of the hour. Now coming to the confidentiality, what kind of say arrangement we make with celebrity? For us, patient is a patient, though it is to some extent theoretical. Patient is a patient, whether he is a grade 4 employee or a celebrity. The way of treatment and way of disclosure, the amount of disclosure will go as per the guideline. And it is not possible all the time that we shall control the attendance or something. So there should be a proper mechanism in the hospital itself, have to stop the media people, or there should be only one person who will deal with all kinds of disclosure issues. It is not that the treating doctor will deal with all the treatment procedure also, and he will also deal with media, he will give the press release, everything. So there should be one person designed for that purpose who will go through all the required guidelines and thereafter disclose whatever is permitted under the regulatory bodies.
They ask the consultant over phone also about the patient's condition and what disease he is suffering from. So that is also actually
Legally, this cannot be disclosed.
My first question to Dr. Boksanto Hazarika. You have spoken about a very rare disease, and this disease comes with recurrent hemoptysis. As there is no specific treatment, how do you treat these recurrent hemoptysis cases in periphery and also in your medical college?
Treatment of hemoptysis is a symptomatic. First, we have to find out the causes of hemoptysis. Those rare cases, the treatment is also not satisfactory. Symptomatic treatment is same, but definite treatment is in the rare cases. Is in our cases, there is no definite treatment.
My question is, give a guideline how to control hemoptysis.
Yeah, it is very simple. First, what our practice is, we give hemostasis, but hemostasis is not work in hemoptysis. If it is capillary bleeding is there, very mild hemoptysis or blood stick is put on, then hemostatic with egg. Otherwise, if it is a massive hemoptysis, if it is bronchial arterial bleeding, it is very difficult to control with hemoptysis. Then so we have to give supportive treatment, blood transfusions, and same thing. So then so we go to the bronchial artery embolizations, or if it is recurs, then so we resect the patient.
Thank you, Dr. Bokonto. I think this requires long discussion. I think lunchtime is a waste time.
Dr. Das, I was a superintendent of civil hospital Nagaon for long years. Many patients are brought by some people and left in the hospital with injured. Police is not there, then the students are also not there. From whom you will take consent to do a surgery or to do some emergency treatment? There is nobody. From where? Police, if you inform Nagaon police, they will come after half an hour. So in this patient, should we not treat the patient without consent, or we should take the patient? Consent.
Section 92 of Indian Penal Code specifically mentions about that actually in such emergency conditions where the action is done in good faith for the benefit of the particular patient, that can be done even without consent if it necessitates a particular operation or a particular treatment for life-saving purpose or for treatment purpose which will be beneficial for that particular patient. That's it.
So last question. Last question. I think Pritam, he is waiting. You will discuss in the lunchtime.
Okay.
Sorry.
No, just one question to Bokontoda. There's one slide Bokontoda has shown, echocardiographic findings. So that actually looks like a right atrial myxoma. Could you rule out myxoma in this patient?
Yeah, actually, cardiac MRI was done. It is not myxoma. I did not forget to mention it. It is thrombus.
I would have loved to see the video actually.
Any question to Professor Gogoi, sir? This is the last question.
Sir, it is not the last question, it is entertainment question. Because in my days, I'll say rather our days, Dr. Gogoi, me and all, we used to play games with the patients. बताओ ये चेहरा देख के क्या क्या बीमारी तुमको पता लगता है? Tell me. I think this is a very nice game because he has dealt with the hand, even with the face, with gait, right? We can make jokes also, but then this is a very good way to enter into the condition of the patient before knowing what he is suffering from. And this should be regularly practiced in, at least in teaching hospital. Just looking at the patient, how many diagnoses you can make, and later on when you examine the patient, how far you can go to the nearer to the correct diagnosis. Thank you.
Thank you, sir.
I think
the excellent session.
This sort of talk should be, these are entertaining also, but then educative also. This should be included in every.
Thank you, sir,
Thank
for
you.
your suggestion. I thank my all co-chairs and the speakers for an excellent session, and thanking the organizers. We will end up the session. Thank you.
Request the speakers to kindly come on stage for a group photograph to capture the moment. Well, we started the day with a bang. To continue with the same enthusiasm and the energy, we have the next session on hematology and oncology. We'll be having 3 talks: focused clinical examination and investigative approach in a case of anemia by Dr. Nurottam Sonowal, recent advances in targetable therapeutics in advanced NSCLC, Dr. Nilakshi Mohanta, and palliative management in cancers, Dr. Smita Das. To chair the sessions, I would like to request Dr. Amrit Bhattacharya sir, Dr. T.R. Chaudhary sir, Dr. Ramananda Pathak sir, Dr. P.K. Nath sir, Dr. Rajiv Kumar Borua sir, and Dr. Thaneshwar Borua sir to kindly come on stage.
Good morning. So we are going to start the next session, Hematology and Oncology. Our first speaker is Dr. Narottam Sonowal, and he will speak on clinical examination and investigation in a case of anemia. I request Dr. Sonowal to start his presentation.
Honorable Chairperson, respected my teachers, seniors, colleagues and student friends. Anemia is a very vast subject, so it's very difficult to complete in such a stipulated short time. I'm going to focus clinical examination and investigative approach in a case of anemia. Overview: anemia is a state in which the level of hemoglobin in below normal range appropriate for age, sex and attitude. According to the World Health Organization, the anemia defined as hemoglobin level less than 3 gram per deciliter, and in case of men and female 12 gram per deciliter in case of women. Regarding the prevalence, the anemia, here the worldwide prevalence of reproductive age group of anemia in females, here the sub-Saharan Africa's, Eastern Mediterranean and Southeast Asia's are the highest prevalence and the lowest prevalences in anemia. So with this, the focused approach, the clinical examination and investigations, first of all, the importance is the focus history is very important. So the patient's medical history, the dietary habit and nutritional intake, as the various causes of anemia are due to dietary habits, so it is very important. Then menstrual history, as the female reproductive age group is the more prone to develop anemia, that's why thorough menstrual history is very important. Next, after this focused clinical history, we are going for focused clinical examination. In the examination, we have to be the patient presenting with the signs and symptoms of fever, malaise, weakness, patient coming with the chest pain, patient may coming with the palpitations, patient may coming with the history of gastrointestinal bleeding, and the patient may have abdominal pain, patient may have ecchymosis. So there is so much of the constitutional symptoms may present in approaching to the doctors. So the focused clinical examination is very important. Then on the general survey, we have to do the anemia, varying degrees of anemia. We are examining the icterus, if the patients have easy bruising, if the patients have claudications. So in the nail beds and glossitis, if the patients have the stomatitis, we have to limb adenopathy. And on the systemic examination, we have to check the cardiovascular system is very important, as the patients complicated with heart failure. So hemic murmur, or if we examine the chest, we getting and in the abdominal examination, we getting the hepatosplenomegaly is very important. After this thorough focused clinical examination, we go for the focused investigations. The investigation very important for the evaluation of anemia is complete blood count, reticulocyte count, serum iron study, vitamin A and vitamin estimations, B12 and folic acids, and hemoglobin electrophoresis is very important, comb test, and bone marrow estimation. After this clinical examination and investigation, we have to classify the anemia. Anemia can be classified in the various ways. It can be etiological classifications, it may be morphological classifications. I am going to focus here with the the interpretation according to the pathophysiological characteristics. According to the pathophysiological characteristics, anemia can be classified. It may be absolute anemia due to reduced red cell volume, and it may be a relative anemia due to increased plasma volume. So here in the absolute groups, we can, various causes are there. It is due to decreased red cell productions, increased red cell destructions, and due to blood loss. So the first category here, the decreased productions, we may get acquired causes and hereditary causes. In acquired causes, they have a pluripotent hematopoietic stem cell abnormality. It is due to autoimmune, or it may be anemia and leukemia. And other groups, they have erythroid progenitor cell failure. Here it may be due to pure red cell aplasia, or it may be due to endocrine disorders. Then another group, in the acquired group, here the functional impairment of erythroid and other progenitor cell abnormality. They have a megaloblastic features and iron deficiency. The other group, hereditary group, if it is due to pluripotent hematopoietic stem cell, here there Fanconi anemia, and the second here is the erythroid progenitor failure. We may get Diamond Blackfan syndrome, and the functional here we get due to megaloblastic iron deficiency and thalassemia. The other group due to increased destruction, here the acquired causes and hereditary causes. In acquired causes, there may be mechanical, it may be due to antibody mediated, it may be due to hyperosmolism, it may be due to red cell membrane defect, it may be due to mechanical injury or physical injury. So all that should be evaluated. Then the hereditary causes again, it may be then hemoglobinopathies or unstable hemoglobin. It may some other due to like red cell membrane defect, enzymatic defect, and some porphyrias like congenital porphyrias and the hepatic porphyrias. The other group due to increased blood loss, it will be acute blood loss, or it may be splenic sequestration of the crisis. Then the other group due to the increased plasma volume group, here we may get macroglobulinemia. It may be due to pregnancy and athletes. So after this, focused evaluations, we go for narrow the diagnosis. We should do the reticulocyte count. The reticulocyte count, if it is less than 2.5, if it is more than 2.5. Then we go for, if it is less than 2.5, we go for the MCB test. That means red cell morphology. If it is macrocytic anemia, the MCB is more than 100. Hypoproliferative type of anemia, then we should think about it may be a vitamin B12 deficiency, it may be folate deficiency, it may be alcoholic liver disease, it may be hypothyroidism, it may be myelodysplasia. And in the normocytic group here, the 80 to 100 femtoliters, then we go for, we can think about the anemia of inflammation, renal failure, marrow failure, and if it is due to the microcytic group, MCB less than 80, then we can think about iron deficiency anemia, thalassemia, anemia of inflammation, sideroblastic anemia, and lead poisoning. So with this, we are further narrowing the case studies is very important. So regarding the case studies, the first case, it is the 18 years old female patients presenting with easy fatigability and breathlessness. On examination, we get pallor. So in the CBC findings here, RBC is it is low, 2.8, and the hemoglobin is low, and the MCB is low, and MCH is low. Here the red cell distribution white, it is increased. Then peripheral blood smear shows it is the patients with microcytic hypochromic cells, and the red cell distribution white more than 18%. Again, what are the diagnosis? Differential diagnosis. So with this, the CBC and peripheral blood smear shows the microcytic hypochromic RBCs. So we can go for the 4 differential diagnoses: iron deficiency anemia, beta thalassemia trait, lead poisoning, and anemia of chronic disease. So what are the further investigation we have to do? Definitely it is iron studies. In the iron studies, we may get serum iron is low, ferritin is low, TIBC is increased, and transparent saturation is decreased. Here, the most important, we have to do the reticulocyte count Manjar index. If the Manjar index is high, then we can think about it is due to the, signifies the iron deficiency anemia. So definitely, what is your diagnosis? The diagnosis is the iron deficiency anemia. So I am going to my next case here, 29-year-old pregnant lady coming with mild pallor with these CBC findings. So in the CBC findings, what we are in the slides here, hemoglobin, it is low, 10.1 gram per deciliter, MCB 60.8 femtoliter, and MCA is 18.5 picograms, low, and red cell distribution wide 16.9, it is high. The peripheral smear examination here, we may get microcytic hypochromic cells, then RBC count more than 5 million, then hemoglobin percentage, it is slightly low 10 to 12, then red cell distribution wide less than 18%, and target cell seen. And others, in the serum studies, we may get serum iron normal, ferritin normal or mild decrease, TIBC normal, transparent saturation normal, then Manjar index, it is less than 13. So again, we have to do the hemoglobin electrophoresis here. Hemoglobin electrophoresis shows the F concentration is 0.8% and the A2 concentration is 5.4%. So the diagnosis is beta thalassemia trait. I am going to the third case here. The last case, so the 25-year-old male coming with weight loss and jaundice. On examination, we may get here the cellitis, pallor, yellowish discoloration of sclera, CBC findings, WBC 2.06 per 10 to the power 3 microliter, and RBC 1.61 into 10 to the power 6, then hemoglobin 6 gram per deciliter, hematocrit 18.6, and MCV, it is high, it is 115 femtoliter, then red cell distribution wide, it is 29%, then platelet count 56 into 10 to the power 6, it is low, then NOBC is 3/100 WBC. Then peripheral smear examination, we may get microcytic cells and red cell distribution wide is more than 18%. Then other, in the peripheral blood smear, hypersegmented neutrophils may get, then Howell jelly body and basophil sibling. So based on this CBC findings and peripheral smear examination shows the macrocytic RBCs. So what are the differential diagnoses? The differential diagnosis, one is the megaloblastic anemia, another one is liver disease, another one is drug that impair DNA synthesis, next one is myelodysplastic syndrome. So based on these findings and differential diagnosis, which investigation can be done further? So definitely we have to do the vitamin B12 and folic acid estimation. If the vitamin B12 it is normal and serum folate is decreased, then we can think about what is the diagnosis? Diagnosis is megaloblastic anemia. So with all that physical examination, history and focused investigations, the take-home key takeaways for the house is the comprehensive assessment, detailed medical history is very important, thorough physical examination is very important for evaluation of anemia, then clinical findings, pallor, fatigue, organ system should be examined properly, if it is involved or not, then laboratory investigations, CBC, peripheral blood smear, iron studies, and vitamin levels. So if necessary, we should go for the specialized test for further. If we cannot, diagnosis is very difficult, then we go for the special test. The differential diagnosis is very important to treat the anemia. So for narrowing down, because it is a very broad classifications of anemias are there. So the narrowed down the proper clinical diagnosis and evaluation and for plan of treatment is very important. Thank you.
Hello. Before starting the second, session, we have a important announcement from the organizer. So please.
So sorry to interrupt the session, but I just had a small announcement to make. We have also started the platform paper presentation in the adjacent hall. So both the sessions will go on simultaneously. I would like to request our respected delegates and faculties to kindly go and encourage our postgraduate students in between. Thank you so much. I would like to hand over the mic back to the chairpersons.
Thank you. Now our next session is yes. Research Advance in Targetable Therapeutics in Advanced NSCLC. So I request Dr. Nilakshi Mohanto to come over the rise and deliver her lecture. So previously, when we were taught about lung cancer, the oat cell carcinoma from the beginning of the, first detection of the oat cell carcinoma, total patient is surviving for 6 weeks only. So now the oat cell carcinoma or the small cell carcinoma, this is not very favorable, course is not very favorable, but NSCLC, if we will treat properly, then we can save the patient and prolong the life up to 5 years even. So with targetable therapy, what we can do, let us listen to Nilakshi, please.
Respected chairpersons, my seniors, teachers, colleagues, and dear friends. Indeed, I'm greatly honored today to be in this platform. And I bring warm greetings from State Cancer Institute and shall be taking you on a brief little journey into the life in oncology and the life of a cancer patient and the journey that we share with them. So we surely need to know what's the cancer scenario in the northeast part of India, and today northeast is considered to be the cancer capital of the country. With an average incidence of cancer every year from 90 to 120 per lakh population, which is the national average, we in the northeast have a burden which is as high as 220 to 270 per lakh population. Certainly an important point to ponder. And some of the highest cancers that we are seeing are esophagus cancer and lung cancer, particularly in the male population. State Cancer Institute, Guwahati Medical College is one of the first state government-initiated comprehensive cancer care centers, which was inaugurated in 2017 with an aim to cater to the needs of the people of this region. Today, we have an average footfall nearing of 40,000 patients annually and approximately 8,000 new patients in this institute. It is becoming a beacon of ray of hope for the people of this region. This is the journey of a cancer patient, and it's almost like boarding a train. And the ride may be smooth or bumpy. We all need to remember, whether it's a patient or whether it's any of us, each of us are anyway going to the same destination. What's the ride going to be like? That's the question. And therefore, when a patient is coming with a diagnosis of cancer, there is all these steps that go in between, from diagnosis to the various treatment plannings, to the various therapies which go on, could be for months or even years. Thereafter, it could either be a disease progression or there could be a survivor. And who are the people walking hand in hand with this patient? They could be starting from the nurse in the periphery to the general practitioner to the oncologist professionals, be it a radiation, surgical, or medical oncologist, the diagnostic group, and the palliative team, and so on and so forth. So it's a long arduous journey, but we make sure that we hold the hands of the patient throughout. And I'd like to give the example of Mr. H. He came to my OPD just a week back. This picture was taken a week back. But what I'd like to say is what is often considered the end of the road for a patient diagnosed with cancer is but the beginning of a new journey with immense possibilities. Mr. H was actually diagnosed with lung cancer in 2010, and today is 2023. And he is a stage 4 cancer patient with his sheer willpower to live well, along with access to all neurotherapeutic modalities. Life has given him a second chance, and he is surely living it well. We'll come back to his story once again, but what's the treatment plan of a cancer patient? Cancer treatment is not just a prescription, it is a plan. And what is it based on? It's based on these two major factors. What is the type or the biology of the cancer, histopathologically, molecularly, and genomics? What is the stage of cancer? Based on that, we have two intentions of treatment. Are we going to cure this cancer? Is it an early stage? Is there a scope of radical treatment? Or is this a palliative or an advanced stage cancer? And these are the 5 broad modalities of treatment. It could be surgical, radiation, all these are the specialized, highly advanced radiation technologies, chemotherapy, targeted therapy, biologics, monoclonal antibodies, immunotherapies. This is what a medical oncologist deals with. Nuclear medicine with theranostics, newer nuclear medicine techniques, and palliative care. And the treatment plan is a combination of above. It could be a concurrent or a sequential treatment. So first we evaluate, then we diagnose, then we stage, then we plan, then we endorse in a multidisciplinary tumor board, then we execute the plan, then we assess and follow up. So that's the entire journey of the cancer patient. And today when we talk of metastatic disease, what are we talking about? Because today is an era of precision medicine or personalized medicine. There are tremendous advances, phenomenal advances in the genetic and molecular profiling of these patients with cutting-edge technology and newer targeted therapies like TKIs, that's tyrosine kinase inhibitors, monoclonal antibodies. They have revolutionized cancer care with significant overall survival and progression-free survival benefits. And of course, today's talk is in the context of metastatic non-small cell lung cancers with mutations like EGFR, ALK, ROS, which can be treated with targeted therapies with fascinating, fantastic outcomes. This is the big problem that we are facing. As we can see from 2018 onwards, the numbers are only going to rise. These are the predictions, and we are seeing. But the issue is not about the numbers rising. The issue is about whether we can control them, whether we can control cancer just like a chronic disease like hypertension or diabetes, or do we just give a death sentence like this, the end of the road? No, cancer has become almost like a chronic disease today. So these are the broad classification of the histology of cancer, and lung adenocarcinoma is what we see majorly, apart from squamous cell carcinoma. Small cell has a completely different treatment, different biology, and a treatment plan. So basically, these are the intents of cancer treatment. Either we can cure them if they are in stage 1, 2, and 3, or we can control them if they are in stage 4, or we can just give them the best supportive care, that is palliative care. Cancer treatment should be available, affordable, and accessible in comprehensive cancer care centers. In the Western countries, most of the patients come, 70% are coming in the curative intent, in the curative stage. Only 30% come in the late stage. So here comes the importance of awareness of the disease. So these are the histological subtypes. As you can see, adenocarcinoma, almost 40%, takes up the major burden with a lot of mutations. However, what we have seen in this was one of our studies which we presented at ESMO Singapore, that's the European Society of Medical Oncology, and we found a relatively larger number of adenocarcinomas, close to 60% in our subgroup of patients. So definitely the biology of or the demographics of the Northeast population could be quite different from the rest of the world. And this is based on staging. We can stage them as stage 1, 2, and 3, where we are going to give curative intent treatment with a combination of surgery, chemo, and radiation. That's a multimodality approach. And if it is a stage 4, today we are looking at chemo, targeted, or immune checkpoint inhibitors, which is usually a single modality treatment for these advanced cases. So today, these are the basic Means of treating metastatic or advanced cancers: if you don't have a targetable mutation, then go for chemotherapy. If you have targetable and oncogenic driver, then you can go for TKIs. And these are the 3 common mutations that we often see: EGFR, ALK, and ROS. And third comes the checkpoint inhibitors, that's the immunotherapy, which is the new buzz of the era. So today, NSCLC evolution, it has become evolutionized into all these various biological subtypes, as you can see: EGFR, ALK, ROS, PIK3CA1, HER2, so on and so forth. And treatment selection is moving from histology-based to targeted-based oncogenic driver treatments. But how are we going to treat this? How are we going to choose the patient? Is this patient as good as this, or is he coming on a wheelchair? So if the patient is this kind of a patient, that's a performance status 0 or 1 or 2, then the chances of survival are quite good. Whereas if it's this, then probably this patient would require more palliative care. So this is the broad treatment algorithm. Non-squamous cell carcinoma, we look for the mutations and consider the targeted treatments. If they are wild type, then they will go for platinum-based doublet therapy, usually pemetrexed and carboplatin. And in squamous, of course, I'll not go into that. So basically, it's about precision. You would not wear just any pair of glasses. Your prescription is tailored to your vision. Each of us have a different pair of glasses. So today, lung cancer, our prescription is tailored to the biology of the disease. So this is how, again, chemo targeted versus the immunotherapy from 1970s to 2015 and onwards. This is where we stand today. So I will just briefly touch upon how we decide. First, you go for the tissue diagnosis, the biopsy, histopathology, find out whether it's adeno or clear cell or other type. Determine, go for the molecular markers, look for these 3 common mutations. There are a host of others. There are more than 100 mutations today, but we are looking mainly at about 5 gene, 8 gene, or 12 gene panel. Look for the PD-L1 expression, because this is important if we think of immunotherapy. And if there is a progression of the disease, always take a new biopsy if possible, because the molecular profile can change with time. So these are the standard molecular testing that we do. Even in our setup, we are doing these as a standard of care, and these are some of the preferred ones, are not mandatory. So the common EGFR mutations that we see, so these are the exon 18 to 21. The most commons that we see are exon 19 mutation and exon 21, and these are the common therapies that we give, whether it's gefitinib, erlotinib, afatinib, osimertinib. These are all proven as standard of care, first-line preferred therapy as per the NCCN, that's the National Cancer Care Cooperative Center guidelines that we follow internationally. So these are the landmark studies which have shown the benefit of these TKIs versus standard chemotherapy, and all these studies, whether it's the optimal Eurotrack or Lux Lung studies, have shown a major ORR benefit, that's the overall response rate, and the survival benefits of these patients. And that's why today they have become a standard of care. The next common mutation we see is the ALK rearrangements in lung cancer. Approximately 5 to 7% as per literature. Interestingly, in our study, which we presented at ESMO, we found 33% of ALK mutations positive. We see more in young patients. We see more in never smokers. Our youngest ALK positive lung cancer patient is a 22-year-old girl. Most of them are working. They are professionals. They are artists. They are dancers. They come from faraway places, and they go back and work normally. They are having an absolutely normal life because of the targeted treatment for which their disease is responding today. So they are quite a different subset of patients that we see, unlike the EGFR patients. But in ALK positive, what we are seeing is that there is a lot of brain metastasis. That's a very common site of metastasis. So the newer drugs are being developed to see that they are drugs which cross the blood-brain barrier. So this is the timeline of ALK inhibitors that we have seen from 2007 onwards till today. And today, crizotinib, ceritinib, these are drugs that we give in our hospital, which are free for the patients if they are under the PMJY schemes. And newer drugs like lorlatinib are still in the pipe. They are already available in the market, of course, at a pretty high price. So there's a paradigm shift in the targeted therapies, whether it's EGFR, ALK, ROS, BRAF, MET, RET, and as we can see, a host of these TKIs are coming up. And if a patient does not have these mutations, then we have to go for the standard doublet platinum-based chemotherapy regimens. So our SCI data, which we presented at 2022, we found most of our patients were non-smokers, and adenocarcinoma was the common histology. EGFR was commonest, but ALK we found as 33.33% as versus the global data of around 7 to 10%. And exon 19 was the commonest mutation that we found. So immunotherapy is the latest game changer that we are having, and pembrolizumab, atezolizumab, nivolumab, which is available again, which we are giving the benefit to this patient. The immune checkpoint inhibitors basically put a brake on the system in such a way that they bind upon these ligands and help the T cell to start killing the tumor cells itself. So it is enhancing our own immune system to kill the cancer cells. To summarize, what should a physician do? If you have a suspicious lesion, send for the biopsy, at least let us know what it's non-small cell lung cancer or small cell, adeno versus squamous, send the tissue block if referred to a higher center. If the patient comes with the tissue block, it will be beneficial for us. The further on, we will go for staging to decide the intent of treatment. If it's stage 4, we will go for palliative. We will send for the molecular markers, which we are also doing in our newly set up molecular oncology lab at State Cancer Institute. And then we make the treatment plan. If it's a mutation positive, we'll go for targeted therapy. If it's negative, we'll go for PAL-CT plus minus immune checkpoint inhibitors. Multidisciplinary tumor board is something that is existent in most cancer care centers, and it is very much an integral part of State Cancer Institute. Every day we discuss each and every new OPD patient which is planned for a cancer treatment. The entire journey of the patient is endorsed in this particular tumor board, which consists of all the specialties from all the oncology specialties, diagnostic specialty, and the palliative team also. So the treatment of metastatic sites, Dr. Smita is going to take over, so she'll be discussing more of this. All the pleurodesis, brain mets, giving medical decompression, bone mets care, palliative care is an integral part of comprehensive cancer care. Coming back to the journey of Mr. H, he had a right lobectomy in 2010, then adjuvant chemotherapy. His disease progressed in 2017. He was EGFR positive. He was started on first-line gefitinib. Again, disease progressed in 21. Started on PAL-CT second line. Again progressed and got osimertinib from June 21 to 22. That was the third line. Again got palliative chemotherapy, fourth line. Disease progressed in March 22, and now he's on afatinib, going well with the fifth line of treatment. So take-home message. There is a huge shift in what we know about cancer. Today, new targets are constantly emerging. There are shifting treatment options, even in early stages today. So the future, do we have a cure for metastatic disease? Systemic targeted therapies or immunotherapies, even for localized disease? Questions are many, possibilities are few. I once again bring warm greetings from State Cancer Institute. We started as a seed, and today we have just become a small sapling, but we are trying our best to see that our patients don't have to go to very faraway places to get some basic cancer care treatment. And once again, I thank you all for a very patient hearing.
Thank you, Professor Nilakshi, for excellent presentations. And you have covered everything in a very short time. And we'll take few questions after the third session is over.
Thank
third
you so
speaker.
much. Thank you so much.
So I call upon the next speaker. Dr. Smita Das. She will talk about palliative management in cancers.
A very good morning. I thank the organizing committee for giving me an esteemed podium to speak in front of such an august gathering. I shall be speaking on management in cancer. I shall be speaking on palliative management in cancer. The word palliative comes from the Latin word pallium, which means cloak and cover. And if we go by the Cambridge dictionary, it means something that makes the problem seem less serious, but does not solve the problem, but makes it disappear. It was first coined by Dr. Balfour Mount. He is considered as the father of palliative care in North America. According to WHO, palliative care is an approach that improves the quality of life of patients and the families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Out of all the diseases which requires the palliative care, the maximum chunk is taken by the cardiovascular system, which ranges from 38.5%, closely followed by cancer, 34%. And there are other myriads of diseases ranging from neurological diseases, Parkinson's, CKD, CLD, drug-resistant tuberculosis, which require palliative care. Coming to aims and objectives, the goal is to improve the quality of life of patients and their families and caregivers, and to remove the obstacles that negatively impact their daily activities. And the focus is always on the relief of challenges associated with its life-threatening illness, whether physical, psychological, social, and spiritual. And to receive to this goal, we need a multidisciplinary team, and the team consists of, besides the specialists or the oncologists, a very competent team which is capable of dealing all these conditions, and this comprises of the palliative care trained nurses, social workers, spiritual counselors, psychologists, family members, and even volunteers. There are certain difficult questions to deal with while going to the palliative care, includes the physical, emotional and coping, where there is depression, anxiety, and fear with the cancer diagnosis and treatment. Then there is spiritual needs. There are the needs for the caregivers as well, and some practical needs like financial and legal worries, insurance, employment, leave, etc. There are 4 stages of palliative care. In the stage 1, it is stable, where we need to develop and implement certain care plan, like how we are going to treat this patient. In stage 2, which is unstable, we have to adjust the care plan and prepare it emotionally as the patient becomes more and more unstable. The third stage is deteriorating, where we shift the care to the shifting of end-of-life care. And finally, in the stage 4, which is terminal, and we have to change the plan to symptom management, emotional and spiritual care. There are certain models of palliative care, which includes the hospice care, palliative care programs, outpatient palliative care programs, and community palliative programs, where there is a consultative team which collaborates with the hospice to support the seriously ill. This is an integrated model of palliative care, where in the x-axis we see there is the time frame, which as the patient progresses from acute to chronic and to advanced life-threatening condition, and finally to bereavement. And in the y-axis we see the focus of care. And the treatment will start from the anti-cancer treatment will start from the curative, and finally it will go to supportive, and there to the end of care. So this is this image shows that the palliative approach is like the first we have to plan out the approach, thereafter we have to give the palliative care proper up till the end of life. There is a national consensus project for quality palliative care, which we call it the NCP guidelines. It creates a blueprint for the gold standard palliative care for all people living with serious illness, regardless of their diagnosis, prognosis, age, or setting. It was developed by 17 national organizations. Over 90 national organizations have endorsed and supported the 4th edition, which is the current edition. The NCP guidelines 4th edition has outlined 8 domains, and domain 1 is related to the structure and process of care, where the interdisciplinary team was informed, and they are selected, and they are all qualified and educated and trained to give the optimal patient care. So the number 2 domain is the physical aspect of care. Number 3 is the psychological and psychiatric aspect. 4th deals with the social aspect of care. And 5th, the spiritual, religious, and existential aspect of care. 6th, cultural aspect of care. 7th is the care of the patient nearing the end of life. And 8th is the ethical and legal aspect of care, where we focus on the ethical imperatives and processes to support the patient autonomy. So this is an image just to show that how we are going to deal with the physical symptoms, psychosocial and spiritual issues, then the other needs as well. So whenever there is an integrated one, there is less likelihood of receiving chemotherapy in the last 30 days of life, better quality of life, free from anxiety and stress disorders. The palliative care of treatment is always based on the palliative chemotherapy as such. Then there is palliative radiation therapy, palliative targeted therapy, palliative hormone therapy, and even palliative surgical therapy. So the aim is always to reduce the tumor size and improve the symptoms, but it does not aim to cure the cancer as such. So when we say that the patient will be receiving chemotherapy, the patient and attendant may be worried why we are giving the palliative. It is, but what we know from the previous lecture also, that the chemotherapy is one of the chemotherapy, is the primary chemotherapy with the intent to cure. Then the next is the neoadjuvant chemotherapy, adjuvant chemotherapy, and finally the palliative chemotherapy. But when the patient asks that whether we should, why should I be receiving palliative chemotherapy, we must know that palliative chemotherapy is nothing but the same medication as the it is the same medication as the primary chemotherapy itself, but with a slight modification in the combination as well as the dose modification. And the goal of each approach is different. It is not to cure the cancer, but to improve it. And the most important of all is to ease the transition from failing health to end of life process. Then there is a palliative targeted therapy, and this is against, it is same like the other as the curative intent, only the dose modification is there. It is against the molecular markers. Then there is a hormone therapy, which is the corticosteroid, where we use the corticosteroid, and then there is also endocrine therapy, especially for breast and prostate cancer. Then there is palliative radiation therapy, which aims to ease the pain which comes from the bone metastasis or spinal cord compression. Then there is the role to reverse the neurological damage that could lead to paralysis and paresthesia and to debulking tumor. Even the same, the surgical intervention is also to remove the obstruction, debulking, and fracture treatment. Then there are so many symptoms which are associated with the palliative care, which includes anorexia, cachexia, dyspnea, mobility issues. They are all dealt by various, for example, the nutritionist, then the respiratory therapist, the physiotherapist, and but out of all these symptoms, pain is an integral part of cancer, cancer symptoms. And this cancer pain management is done by following the WHO analgesic ladder, where the first step is always the use of non-opioid plus optional adjuvant analgesics for mild pain. Then step 2 for weak opioid plus non-opioid plus adjuvant analgesics. And step 3 is strong opioid plus non-opioid plus adjuvant analgesics for moderate to severe pain. So this diagram shows the analgesic ladder, where for the mild pain we can use paracetamol and NSAIDs. For the moderate pain we can use codeine and tramadol, and for severe pain, morphine, oxycodone, and fentanyl. Then the psychological issues and spiritual issues, it is always there in cancer, the fear, anxiety, and we have to make, management should be such that the patient can live a life of dignity and they can cope with the problem. So here we require the needs of psychologists and psychotherapists who can help the patient to to fight against the fears, worries, and emotions. The other needs, for example, practical needs such as decision-making, financial support, social service providers, cultural needs, go ahead with the language barrier, ethical and legal aspects are also to be taken care. Then the question arises how soon and how often to receive palliative care. It has been shown nowadays that palliative care shows improved results when it is started early. Cancer patients and families are recommended to discuss this with their oncologists. And the frequency of receiving palliative care also depends on the different type of patient and their response. And the multiple follow-up is always required rather than for a single consultations. And the palliation therapy should be, palliation therapy should be started from the beginning itself. So there are certain challenges in the palliative management in India. These obstacles are the population density, poverty, geographical diversity, restrictive policies of regarding opioid prescriptions, limited national palliative care policy, and lack of trained workforces. So, sorry. So to summarize, palliative management is a continuous symptomatic and supportive care from time the patient is first referred until the death is, and that is the basic aim. And palliative care does not depend on whether the condition can be cured or not, and it can be given at all stages. It is meant to improve the quality of life of patients, providing relief from pain, and the guidelines with which the consent should be adhered. And we should not forget that in our society, in an aggressive pursuit to cure for cancer, we shouldn't neglect the symptom control and comfort care. And the consent is very important because we have to explain to the patient what a therapy alternative benefits, harms, and risks are there. So they should be all told. But in that process, we should not confuse the patient and their relatives. So ending my slide, I echo as Anne Richardson has said, if we cannot change the outcome, at least we can affect the journey. Thank you for listening.
Thank you, Dr. Smita Das, and you have nicely presented the subject.
Thank you, sir.
And your eye-opening talk. Then all three papers are open for discussion for audience.
Thanks, Margaret. Thanks to all the speakers for their nice presentations.
Sure.
I think we have some questions from the audience.
Yeah.
So over to audience for your valuable questions and suggestions, please.
Thank you. Very good session and excellent presentations by all the three speakers. I just have a query. It's not a query, just a discussion. Dr. Nilakshi, please. My question to Dr. Nilakshi is that, you know what I'm going to ask you. Many of the time in our practice, we have found and we find the patients come to us, non-smoker, apparently healthy, never had any other symptoms earlier. Just with very simple symptoms like persistent cough for a few weeks or few months, no loss of weight, no history of smoking. And they come to us, and incidentally we do some tests. We get a mass in the lung. Then we do the CT, we get more confirmation. Then we do the tissue biopsy. By the time of the result of the tissue biopsy, we very often find two people who are very closely related to me. One was my colleague and one was my family member. And by the time of diagnosis, the stage is already stage 4 or beyond. So, do you suggest any vigorous screening any routine screening among the healthy population for lung cancer or any other cancers?
Thank you, Aditya. I can surely understand why you particularly asked this question, because you have been a part of the journey. So the question is that, yes, we are seeing a lot of young patients. We are seeing a lot of non-smokers. We are seeing a lot of these high mutation burden patients, particularly in the Northeast, which is significantly higher than the rest of the country or even other parts of the world. What could be the causes? They can't yet be identified. But regarding screening for lung cancer, as of now in our country with our population, there is no current recommendation of a mass screening policy because it would not be effective in the sense that the cost for such large screening procedures will not give the outcome based on the current incidence of lung cancer. But yes, any person who has a chronic cough, which is at least more than 3 weeks, or any I would say hemoptysis is already an advanced symptom, but any harassing cough or any weight loss should immediately get themselves, even if they are non-smokers or don't have any such high risk factors, should get themselves screened. And very often a chest X-ray will not pick up. And as he has very rightly said, by the time the diagnosis happens, it's already stage 4. But most of the time is lost in the asymptomatic period. Rather than once the symptom sets in, the diagnosis would take 3 to 4 weeks, including right up to the molecular markers. So that is just around 1 month at the most. But what happens is the previous time that we have, the valuable time that we have lost, that a patient would think it's just a cough which would go away, and it doesn't. So if you ask the history, we will often find that the cough was there probably for a much longer time and was ignored.
Yeah, hello. Good morning, everyone. Lovely sessions. So I just want to make 2 notes in the first session that was there with anemia and clinical examination. Probably we are losing the art of clinical examination of a peripheral smear. And what I want to make of note is that during evaluation for a megaloblastic anemia, if you are thinking about megaloblastic anemia, we have to check for RBC folate and not serum folate actually. Serum folate has a very less half-life. You will not get the X-rate amount, number 1. And number 2, I think so we are losing the art of checking the peripheral smear as such. And during our student days, as a graduate student and a postgraduate student, there used to be microscopes across in the medicine ward itself. We won't be going to the pathologies for simple things. And probably this can be brought back again to all the places, even in small things. This is what I wanted to note, because we had been missing, personally a case was there, peripheral smear was not seen properly even by pathologists, and a plasma cell leukemia was missing, and Orunima Baido, when I posted the picture, she said directly this is a plasma cell in a peripheral smear, the diagnosis was plasma cell leukemia. Probably the clinical art has been losing. Thank you so much.
So thank you very much.
One question. My question to Nilaksi Mahanto. Your
This is last
slide is
question.
silent on BRCA1 and BRCA2 test. I have gone to Delhi in several cases. In all cancers, they are advocating BRCA2 and BRCA1 test. What is your comment on BRCA1 and BRCA2 test? And when you advise this test to be done in cancer cases?
So the BRCA1 and BRCA2 are usually, they are genomic markers for hereditary breast and ovarian cancers. So any patient who has a strong family history of cancer, especially breast or ovarian cancer, or they have cancers which occur at very young age, or they have, say, a bilateral breast cancer, or there is an ovary plus a breast cancer in the same patient. So these are the patients who are usually advised to undergo a BRCA testing because there is a therapeutic option. If they are BRCA positive, there are 2 factors. One is that the entire family, all the female members need to undergo genetic counseling for early screening for a possibility. They may be, as we all know the story of Angelina Jolie. So she comes from Ashkenazi Jew, where the incidence of BRCA is very high, and she was BRCA positive. However, not everybody can do what Angelina did. She went for a bilateral mastectomy and a bilateral oophorectomy. We cannot recommend for anybody who has a BRCA positivity to go for that kind of an extreme step, at least not in our country as of now. But they can be certainly identified for early screening so that they can have periodic early screens. In case they have the disease, they can be picked up early. So that, as of now, that's the...
I have got one patient, ovarian cancer, with stage 1. There are two controversies with chemotherapy. Should you go for Opalib, that is PARP inhibitors? Opalib is the common drug in India now. Should you advocate that is PARP inhibitors?
PARP inhibitors, yes.
In stage 1 or not?
No, PARP inhibitors, there is no recommendation of PARP inhibitors like olaparib or rucaparib in stage 1 disease. It is only in recurrent ovarian cancers, that is when they have failed on chemotherapy or progressed on chemotherapy or after completing adjuvant chemotherapy, only then there is a recommendation.
That is the opinion of Dr. Raina of IMST.
Yeah, thank you.
So thank you very much.
Thank you.
And I thank you all the speakers for their beautiful deliberation. Now we conclude this session and hand over the mic to the organizer. Thank you.
I would like to request the speakers to kindly come on stage for a quick... to click a picture together. There's a small announcement. If any postgraduate students are in the hall, we have started the poster presentation judging. So all the postgraduate students are requested to kindly stand by their posters. If any postgraduate students are in the hall, we have started the poster presentation competition outside. I would like to thank all our respected speakers and our chairpersons for beautifully conducting the session. Moving on, next we have our hepatopancreatology session. To chair the same, I would like to request Dr. Dilip Kumar Borua sir, Dr. Birinchi Bora sir, Dr. Debojit Sharma sir, Dr. Mriganka Borua sir, Dr. Bijush Defoisa sir, and Dr. Somen Sarma sir to kindly chair the session. I would like to hand over the mic to the respected chairpersons.
Now we have come to a very important session, day-to-day practice. Initial management of acute pancreatitis by Dr. B.N. Sudhari. Very interesting subjects. Many patients have died in my hand. Also, they have died in Guwahati also. So we want to know how to treat the acute pancreatitis cases and any recent advancement in management of acute pancreatitis than the older days. Dr. B.N. Sudhari, please.
Thank you, Chairperson, sir. Respected Chairpersons, before starting the talk on the initial management of acute pancreatitis, I offer my sincere thanks to Professor Dijen Das, who invite me and giving me the chance to speak such a learned august gathering. So my topic is initial management of acute pancreatitis. So the term acute pancreatitis first described by Nicholas Tulip in 1652. Sorry. Basically, he described the he gave the physiological definition. It is an inflammatory process involving the pancreas and variable extent of involvement of the locoregional organ. And that time, different definition for diagnosis was used. Suppose X-ray, CT scan was not there, even ultrasound was not there, even autopsy and operation. So in 1992, all the GI physicians, GI surgeons, those who are dedicated to treat the pancreatitis, they sit together in Atlanta and they give a uniform definition. That means how we will diagnose the acute pancreatitis by clinically. So these are the clinical diagnostic criteria. Acute onset of epigastric pain or in the left upper quadrant, around 65% of the patients radiating to the back. Number one. Then serum amylase and lipase, it should be more than 3 times, or imaging evidence, either in the form of ultrasounds or CT scan or MRI, showing the acute inflammatory swelling of the pancreas or acute fluid collections of the peripancreatic area. Then out of these 3, if somebody qualified 2, then it is labeled as the acute pancreatitis, which is globally used, and it is a uniform diagnostic criteria. So epidemiologically it varies. Incidence varies from different country to different country and different geographic area. And global incidence is around 30 to 80% per lakh populations. In India, we don't have the population incidence data. But if we see the age group, which are the common age group involved, in India is around 74% are male, which is coincide with the even small little bit of Latin America and North America. In Europe, which is the predominantly in the female part. So this is our Guwahati Medical College data. One of our residents prospectively evaluated 187 acute pancreatitis patients, and we found that our common age group is around 45 years. 30 to 39 years is 45%. And etiologically, these are the common etiology of acute pancreatitis. Most of the cases are gallstone related, alcohol, post-ERCP, post-trauma, idiopathic, and miscellaneous. There are even lots of long lists, but it is very rare. These are the common etiology of the acute pancreatitis. So this is our data. Our common etiology is alcohol. But it may be a referral bias because we get most of the patients from the referred from the periphery, those who are moderately severe or severe pancreatitis. So we don't know what is the exact cause in the society, because most of the mild acute pancreatitis which relieves within 2 to 3 days with a mild pain or vomiting. So maybe the cause may be other things. So the issue is this. What is the meaning of initial period? That is, initial period varies from day 1 to day 7. And how do we manage in these days? So I will go these things with a prototype of our case. Sorry. Back. Sorry. Back. Can I go? Yes. It's a typical case scenario. Who is admitted in our ward. He is a 60 years old male. He has no history of alcohol abuse. He does not have any history of alcohol intake or smoking. He had a upper abdominal pain for 1 day, and pain was severe. Severe epigastric pain, vomiting, and his amylase was 740. And X-ray abdomen was done in emergency, one of the medicine resident. It's found to be the normal. This is a good thing done by a resident in X-ray abdomen, because this is also important examination in acute abdomen in the emergency. Because we can rule out the lots of emergency situation by doing a X-ray abdomen both erect and supine position. And ultrasound done. Ultrasound shows bulky pancreas, mild fluid collection, peripancreatic, and gallbladder stone was present. And bilirubin was 2.8, and ALT was 350, and diagnosis was a case of acute pancreatitis. And CT scan was not done in the day 1. So this is the good things. It's done in the CT scan was not done in the day 1. So what is the, when we will do CT? Can we do the CT in the day one? Of course, not required in day one CT scan, because these are the problem if you do the CT scan in day one. There are no evidence early CT will improve the clinical outcome. Then early detection of necrosis will not change your treatment strategy. Then CT scoring is not superior to your clinical scoring of severity, and early inappropriate CT may increases the duration of hospital stay. Then does not improve clinical outcomes, and it poses extra risks, contrast-induced nephropathy. So in day one, CT, no, except in few situations. Suppose you are in a diagnostic dilemma, whether it is a acute pancreatitis or something others. That is, your diagnostic criteria is not qualified this acute abdomen. Then you can go for the CT scan. Otherwise, no in day one. So, according to the clinical criteria, we can divide into acute pancreatitis in 3 groups. Mild pancreatitis, by definitions, no organ failure, no local or systemic complications. Moderately severe acute pancreatitis, transient on organ failure, which is resolved within 48 hours. And local complications like acute fluid collections or persistent, without persistent organ failure. Severe acute pancreatitis, any cases having persistent organ failure, persist for more than 48 hours, is defined as the severe acute pancreatitis. Organ failure may be single, may be multiples. So, what are the issue in the first week? The first issue is when to refer a patient, because all of us sitting in this hall are not so lucky enough to work in a high-fi hospital like corporate hospital having all facilities, ICUs, interventional radiology, DSA technology, everything is there. So, or not even in medical college also. So, we should know when to refer the patient, number one. Then number two, when we will, suppose I have ICU in my hospital, I have an ICU. When I will admit this patient in ICU, then second is, the most important symptom is pain. So what is the best analgesics? Then these patients are dehydrated. So how fluid I will give? And if it is a biliary pancreatitis having jaundice, did the patient require ERCP so that we can take help the person who is skillful in doing ERCP? Then when to do CT and antibiotic, is there any role of antibiotic? And nutrition, when will we start the feeding of these patients? So I will discuss one by one. So this is the point. If that is qualified by a patient in your OPD, in your emergency, suppose you are working in a small hospital and you are getting this type of patient presenting with SIRS, that is systemic inflammatory response syndrome. Systemic inflammatory response syndrome, all of us we know, tachycardia, tachypnea, temperature, and leukocytosis. Then we should refer this patient if we don't have the ICU facility. Then organ failure, if someone is having persistent organ failure, that means organ failure persists for more than 48 hours, we should refer to a hospital where all facilities are available. So same indications of ICU, persistent organ failure, persistent SIRS, and geriatric age group, more than 65 years. Because these are the people having lots of comorbidity, like COPD, diabetes, nephropathy. So you will be in problem giving the fluid. So don't keep in the general bed or general floor, keep this type of patient in ICU. Then next point is analgesic. What analgesic you will give? This is the most important issue in day 1 and day 2. Because patient is shouting just like a pain, because of pain. So which analgesic you will choose? So we don't have much choice. Either you have to give NSAID or opiate. And concern is regarding the safety. So whether it is safe or unsafe. For NSAID, NSAID causes renal failure, GI bleed, and opioid causes ileus and respiratory depression. So you have to choose the better one. So not much data, comparative data, diclofenac versus pantoprazole. This is the one data I read, did in All India Institute of Medical Science by Mohapatra et al. So they compared pentazocine with a diclofenac. Prospectively, they given in 87 patients by giving diclofenac 75 mg 8 hourly and your pentazocine, which is commonly known as the pentazocine injection, 8 hourly 30 milligram. And they use rescue analgesic fentanyl. That means in between, if the patient not get relief, they use the fentanyl for rescue the pain. So this is the data. In the diclofenac group, there is more requirement of fentanyl, but in pentazocine group, there is less requirement of your fentanyl. And area under the curve in pentazocine group is better pain-free period than the diclofenac group. So pentazocine is one of the good choice for your pain, relief of pain in acute pancreatitis in day 1 and day 2, because majority of the patients, pain is more in the day 1 and day 2. Next is management with fluid. So what is the exactly fluid deficit in a case of acute pancreatitis, and how much and what type of fluid you will give in this type of patients, and how you will guide the fluid therapy. So basic pathology for fluid loss is, it is because of inflammatory process, release of lots of cytokines in the retroperitoneal space, leading to the increased capillary permeability and microvascular dysfunctions, and leading to the leakage of the protein-rich fluid, both in the retroperitoneal as continuation of the inflammation to the system. It causes systemic or subcutaneous or third space fluid collection. So this is the oldest study done in Ranson. What is the exact fluid loss in a case of acute pancreatitis? Ranson identified the fluid loss is approximately 3.7 to 5.6 liters in mild and severe pancreatitis. And D. Madaria, which is a Spanish, he shows the median fluid loss is around 3.2 liters. And the predictors of the high fluid loss is younger age, alcohol. Can I get time? Younger age, alcohol, high glucose, high hematocrit, and high systemic inflammatory response syndrome. These are the predictors of high fluid loss. Then, how aggressive we will fluid loss? 9 studies both reported the rate of fluid infusions, aggressive versus non-aggressive group. In aggressive, 4.5 liters first 24 hours, and non-aggressive, 3.5 liters. That is your bolus 15 to 20, 1.5, and depending upon the response. And what is the result? Result shows there is a favorable response in the moderately aggressive. That means aggressive fluid infusion is also harmful. So better to give approximately 3 to 3.5 liters per day in the case of acute pancreatitis. Then what is the type of fluid? Whether you give RL, ringated lactate, or it is a normal saline. The problem with normal saline is hypochloremic acidosis. So this is the study which shows RL is less likely to develop moderately severe or severe pancreatitis, and no difference in development of the SIRS in RL versus NS. Then RL less likely to require ICU admissions and local complications and shorter hospitalization. So RL is the one of the best fluid to start with. Then how do you monitor? These are the different parameters to monitor. The simplest way to monitor the patients, whether the hydration is adequate or not, you can do one thing. You can check the mean arterial blood pressures, heart rate, and urine output. And otherwise, these are very difficult things, complicated things, or you can do, which we usually do, our residents are doing these things. Either you can see by doing ultrasound, see the IVC diameters. IVC diameter will indicate whether the patient is overhydrated. Sorry. So lots of things to be discussed. Prophylactic antibiotic, no role. Then nutrition, these are the cause of malnutrition. Then acute, when you will start nutrition, the acute pancreatitis, mild acute pancreatitis, pain-free, bile sound presence, you can feed. These are the recommendations. Both enteral and nasojejunal feed is equally effective. Then take the total nutrition is 25 to 30 kilocalorie, even 1000 kilocalorie is sufficient, polymeric diet is sufficient, TPN if needed. So these are the indication of TPN. So basically, this is the take-home message. Acute pancreatitis in first few days is critical. Then adequate and optimum hydration is important. Analgesic opioid is a choice. Early enteral nutrition having decreases the infections and surgery, and no indication of prophylactic antibiotic, and ERCP is infrequently required. Thank you.
That is also very interesting topics. I invite for this topic Dr. Anup Kumar Das. You please come and present your lecture. Thank
you. Okay. Good morning, everybody. Thanks to the organizing committee of the team led by Dr. Atul Saikia and Dizen to have called me here. I'll start by this information that I gathered, one from the USA and the other from the Canada. And it shows that there is a very high increase in hospitalization due to alcoholic hepatitis in the last 1.5 decades. And in Canada, the average monthly admissions of the hepatitis was more during COVID than after COVID, than before COVID. And the most important thing they showed is that there was a disproportionate increase in young adults, females, and minorities. Now, this is the report from the government of India. The key findings were alcohol is the most common substance abused or used. Overall prevalence of alcohol use was 4.6% in India. Male to female ratio being 17:1. And harmful and dependent use was almost 20%. And it was widely different in different stage. These are the different things, prevalence rate in Bangalore, Kolkata, Viluppuram, Chennai, Kerala, Andaman, and all. You can see there is a wide variation, with most in Kolkata. Hazardous drinking in men is defined as 50 units per week, and for women, 35 units per week. 1 unit is approximately equal to 8 grams of alcohol, and different type of alcohol contains different amount of, alcohol. These are the symptoms and effects of alcohol: brain, esophagus, lungs, liver, heart, muscle, pancreas, stomach, everything is affected. And the WHO showed us that the global mortality attributed to alcohol is highest, 50%, due to cirrhosis, compared to other cancers, interpersonal violence. All the others are also effects of alcohol. But alcohol kills 50% of them by producing alcohol-related cirrhosis. Now, coming to alcoholic hepatitis. What is alcoholic hepatitis? So this is the definition by the European Association. Keyhole itu. Itu keyhole. Now, this is a distinct clinical syndrome characterized by rapid onset of jaundice or worsening of jaundice of more than 3 milligrams of bilirubin with or without liver decompensation. What is liver decompensation? There is ascites or encephalopathy. And the third criteria is patients with ongoing alcohol abuse at least in the last 2 months. So these 3 criteria must be present. There may or may not be any chronic liver disease, but there should be recent onset jaundice, and the patient is taking alcohol, whatever amount, in the last 2 months.
And there is no clear threshold of how much the alcohol amount the patient is imbibing, but it occurs after decades. What happens in chronic ethanol intake is that ultimately there is acetaldehyde production on one hand. Here you can see acetaldehyde, and there is some problem in the gut-derived endotoxin. And whatever happens is first fatty liver, then there is a hepatocyte injury, and then there is liver fibrosis. And when the intestines are affected by the direct effects of alcohol, Kupffer cells are affected by endotoxemia, and cytokines are liberated, and hepatic stellate cell stimulation occurs, and there is fibrosis. Now, this is the natural history. Not all alcoholics develop chronic liver disease, but alcoholic steatohepatitis occurs in about 35%, and alcoholic cirrhosis occurs in about 20% of chronic drinkers. And what is most important is that alcoholic cirrhosis can coexist with alcoholic hepatitis in about 80% of cases. An alcoholic cirrhosis patient can develop alcoholic hepatitis in 40% of cases, but it all depends. The right-hand panel shows you some modifying factors or confounding factors, and these are genetics, the gender, the ethnicity, the obesity, other underlying liver disease like associated viral hepatitis or hemochromatosis, nutritional status, iron level, drugs, if the patient is taking some hepatotoxic drugs, and smoking status. Now, the hepatic inflammation which occurs is driven by both intra and extrahepatic effects of alcohol, and they include expansion of liver progenitor cells, which is very important nowadays, because we are talking about targeted therapies nowadays. Then there is genetic predisposition, something like CYP2E1 mutation, which you know is an inducer. Then gut dysbiosis, most important nowadays, and gut integrity disturbance. So, alcoholic hepatitis in a drinker, in an alcoholic drinker, the relation between hepatitis and cirrhosis may be explained simply as an inflammatory step taken by alcoholic hepatitis towards cirrhosis. Now, on the left-hand side, same hepatocellular carcinoma can become the terminal event. On the right-hand side, the histological appearance, they appear in different stages of alcoholic liver disease. And the middle portion is not for us, it's only for the postgraduates. And this is also for the postgraduates. Coming to clinical features of alcoholic hepatitis, we have the patient may have asymptomatic disease, and the patient may have serious unconsciousness and very critical condition, depending upon what happens inside his body. Now, how to define? We have got three definitions. One is probable, one is possible, the other is definite alcoholic hepatitis. Definite alcoholic hepatitis always diagnosed by liver biopsy. We don't want that. So our diagnosis is usually probable alcoholic hepatitis, which is also accepted. This is a clinical diagnosis without potential confounding factors. In the lowermost paragraph, you find the potential confounding factors, and the clinical diagnosis of alcohol is onset of jaundice within the last 60 months, as I said, and ongoing consumption of alcohol before the onset of jaundice, and AST and ALT level between 50 and 400, and the ratio should not be less than 1.5 or 2, and the serum bilirubin level is usually above 3. Now, that is probable, and possible if both are combined, and definite if you have a liver biopsy. But EASL, it recommends liver biopsy to diagnose alcohol, because clinical diagnosis is possible in only 70 to 80% cases, and in 20 to 30% of cases, you need biopsy. Now, in history, what do we do? Female 8 or more drinks per week, male 15 or more drinks per week. That will tell us whether there is significant drinking or not. And regular heavy drinking is more than that, and binge drinking is a very short period of very huge amount of alcohol ingestion within 2 hours. That is binge drinking. All are harmful to the body. These are the biopsy findings, which are peculiar to alcoholic hepatitis, also so diagnostic. This one. Cirrhosis and alcoholic hepatitis can coexist, but if the person has got underlying cirrhosis, there are some differences from alcoholic hepatitis. These are important variables which are used in prognosis of alcoholic hepatitis. Madrid score and MELD, model of end liver disease, end-stage liver disease model, then Glasgow model, then ABIC, and Lilly's model. These are the variables which are used to prognosticate a person with alcoholic hepatitis. And severity in Madrid score is above 32. And in Lilly's score, the severity is above 0.45. This we should always remember. And in MELD score, if the score is above 21, it is very, very severe alcoholic hepatitis. So these scoring tells us what is the prognosis of the patient. And to work up the patient, we have to look at these things, ascertain the use that the person has been using large amount of alcohol, confirm alcohol use disorder, what is the pattern, what is the duration of drinking, what is the ANI score, because we have to also exclude NFLD also. Transient elastography, doubtful, and LFT, GGT, ST-LT ratio, all of you know about these things. Then there are, on the right-hand panel, these are important new sensitive, very highly sensitive tests which can be done in the serum, but very expensive and very not yet probably available, except one. It's very expensive and time consuming, but very sensitive of very heavy drinking. There are no, regarding treatment, there are no approved drugs as of now. Now, if the Madrid score is less than 32 and model of end-stage liver disease is less than 18, there is no treatment except supportive treatment as well as nutrition, which is very important. If the Madrid score is above 54 and the MELD score is above 24, then also there is no treatment except liver transplant. Corticosteroid is only used, which is the mainstay of treatment in our setup, but is suboptimal, and there is a need for novel therapeutic agents. So this is the very simple flow chart by which we treat. We do the Lilly score at day 0 on admission and at day 7. So this Lilly score, when at admission it is less than 0.45, we start steroids. For 28 days, it improves the mortality compared to no treatment. Pentoxifylline has got no treatment, no role in improving the mortality or morbidity. Now, if Lilly score is 0.45, then we have to stop prednisolone. We have to refer the patient for early liver transplant and consider other clinical trials. If the MDF score is mild, the MELD score is mild, no medication, as I said, except supportive. And there are cases which may not respond to corticosteroids, and there is add-ons. These are antioxidants and ethanol-clearing drugs like metatoxin and N-acetylcysteine, but they work not very nicely. So nutrition supplementation is very, very critical, and enteral supplementation is better than parenteral. And these are the factors for poor prognosis. There are a lot of biomarkers now undergoing investigations to predict the diagnosis or prognosis in severe alcoholic hepatitis. And these are the emerging therapies, but newer drugs affecting the gut-liver axis, drugs targeting the inflammatory cascade and stimulating hepatic regeneration with stem cells and GSF are undergoing treatment. These drugs have got no benefit, not recommended, except pentoxifylline. When you find an alcoholic hepatitis patient with kidney injury, you can add pentoxifylline, it works. And early versus late liver transplant important because it improves mortality in early transplant compared to late. These are the future needs. We need a lot of studies, and counseling is very important, and researchers and public health officials, they need to find out how to decrease the alcohol consumption in the society. It's integrated multidisciplinary treatment, and this several promising therapeutics drugs are being examined, and the dual entities of alcohol, hepatitis, and alcohol use disorder should be addressed, thankfully. Thank you.
Thank you, sir. Thank you, sir, for your nice presentation. And we'll go to the second topic. And for this, I request Professor B.D. Goswami, sir, for the management strategy in MASLD. Sir, please.
Respected chairpersons, respected my teachers, my seniors, and my friends. So for next few minutes, let us discuss about the non-alcoholic steatohepatitis, the management strategy, what we should go about. Of course, this is now has been changed. The name has been changed to metabolic dysfunction associated steatotic liver disease. That means MASLD. The name is different when the problem is the same. It's a multi-organ or multi-system disorder. It not only involves the liver, it also involves the heart, arteries, it involves the pancreas, it involves the kidney as well. And it is established today, these are the risk factors like diabetes, obesity, other metabolic conditions, and all of them we have to take care in the management strategy what we make for it. So it is spectrum of the disease. What happens actually basically initially, when there is fatty deposition, we call it steatosis. It goes to steatohepatitis, inflammatory changes. It goes to cirrhosis, and finally it ends up with hepatocellular carcinoma. And that's why as a whole it may be an NFLD, but the problem, it goes step by step. Then this is the scenario actually we see from the normal liver, NASH, fibrosis, cirrhosis, and hepatocellular carcinoma. Step by step it goes. from NFLD, they go to NASH, almost 20 to 30% over 3 years. It goes to fibrosis. From fibrosis, grade 3, for example, it goes to cirrhosis, almost 20% over 2 years. And after that, 30, 40% ultimately go for the so many complications, and there is end of the life. There is liver failure, there is hepatocellular carcinoma, there is liver transplantation, and all this goes on. And most of the time, the death comes from cardiovascular disease. There is carcinoma of the whole body of the human body, and also to some extent there is liver-related one. So that 2 points I wanted to give some mention about is the diabetes as well as the obesity, because the line of treatment, we have to think about these two issues. There is type 2 diabetes and NFLD, and once the patient has got diabetes, it promotes the steatosis, it promotes cirrhosis, it promotes hepatocellular carcinoma. And once the patient has got NFLD, it actually enhances the insulin resistance. There is atherosclerotic or atherogenic dyslipidemia. It is difficult to manage the sugar in those patients, as well as there is a high risk of cardiovascular diseases with this one. Then we have got diabetes mellitus today in the world, almost 380 million people. And if you see from this picture, if they have got diabetes, almost 60 to 80% goes to NASH, 20 to 80% goes to NASH. NFLD, then it is NASH. That is the way it goes on. And problem here is again, the hepatologist or the gastroenterologist, they see a particular number of the patient, not the actual picture. Then we have got the obesity, and also there is diabetes, and also there is NFLD. How it goes on, because the Western lifestyle, then the food habits change everywhere. And that's why it goes to high calorie intake, there is excessive fat intake, there is a high fructose intake, and also sedentary lifestyle, and ultimately ends up with the obesity. If you see this picture similar to the diabetes one again, if obese, 55 to 95% will go for NFLD, and out of that, almost 55% goes to NASH. And today we have got the 1 billion people all over the world with obesity. So you just imagine how many patients we are having with the risk of NFLD, or for that matter, the complications of NFLD. Again, this is a limited picture we have got, because it is a gastroenterologist or a hepatologist see this number of patients. Then if you see the whole scenario, if there is fibrosis, that means it actually leads to so many mortality or morbidity of NFLD. This study shows clearly it increases if F1, F2, F3, F4. So fibrosis score goes on increasing, there is severe liver disease, and also there is high mortality if there is high number of the fibrosis score. Then if you see here, this picture showing, already I mentioned about the complications, the grade 3 or 4 varices, or that matter, it goes for the bleeding, and most of the time, majority of them with mortality. Then, or it goes to the hepatocellular carcinoma. And another important point, the most important point I should mention about is the 3 main causes of death in NFLD. It is not the liver. The number 1 cause is the cardiovascular events, 38%, non-hepatic malignancy, 19%, and only liver-related, 9%. So it is not the liver. Our target should be other than the liver. Now coming to the treatment, what is our plan and what we should do? The goal of the therapy is to prevent the liver injury.
we have to take care of the comorbid conditions and also prevent the fibrosis, because once the fibrosis, it is still reversible. After fibrosis, it is irreversible one. That's why we should stop there itself. So what we have got at any cost, stop liver fibrosis, stop the progression of the disease from that particular point so that we don't have to face the problem. For that method, it is a lifestyle modification, comprehensive lifestyle. Energy intake should be restricted. Coffee consumption should be encouraged. Then again, the diet should be usually healthy diet maintained. Then fructose intake, reduce it. Alcohol, try to stop it or moderate it. And of course, we have to go for the physical activity, 150 to 200 minutes per week, if it is possible. Then it will be very helpful in the management of steatohepatitis. For that matter here is a comprehensive point I am mentioning here about the comorbid condition. You treat the comorbid conditions. For that matter, we have to take the obesity management this way, different way already I have mentioned about. And also we have to think of the cofactors, alcohol, smoking, then fructose intake, and also coffee, what I mentioned, and I'll talk about it later on. Coming to the weight loss, how is the important the weight loss in the NASH management? If 5% weight loss you can gain it or get it, then you can definitely improve the condition of the patient. If it is 7 to 10% weight loss you can achieve, then the NASH score would be definitely reversible. And if you can make it more than 10%, even fibrosis can be definitely reversed. If you see from this picture, a weight or obese person coming to a fit person, right? In the left side it is the Rishi Kapoor, for example, and the right side it is the Shahid Kapoor. So 52 weeks total weight reduction, if you can maintain it, then this is the result. 5%, 7%, 10% weight reduction, you have got the NASH regression, the fibrosis regression, steatotic improvement, everything is possible. Coming to this particular patient who came to me last year in September, when he came, his weight was 108, 52-year male. I checked it, the fibrosis score. Stiffness was 20 and the CAP value was 333. So after 3 months when he came, this time his weight was 85.6. And you see the score coming down to 8.9, 274 CAP value. I followed the patient continuously. After 3 months, 83.3 from 101. So now this value is coming to 7.4 and CAP value is 296. Again he came in May this year. It is 81.2 coming down again. And you see the results of the stiffness coming down to 6.8. Few days back, only 7 days back, he came to me. And this time, his weight is 71, and you see the drastically reduced the fibrosis score, that means the stiffness score, as well as the CAP value. So this is the message I am giving, that if you reduce the weight, you can achieve what you want in the management of NASH. Now coming to coffee, there are so many reports coming up. The use of coffee is very helpful in the management of non-alcoholic fatty liver disease. The studies, I'm so not going in details, it reduces the risk of the fibrosis reduced. Hepatocellular carcinoma risk also is reduced drastically in these patients when taking coffee.
These are different studies again showing the similar results. So we should encourage coffee intake to the patients. Then coming to the diet. So Mediterranean diet is an ideal one for the treatment of NASH or non-alcoholic fatty liver disease. I'm not going again details because time is the restricted one. Then coming to alcohol, I have already mentioned 2 years back, there is a study clearly showing that if the patient is having a NASH, again he takes alcohol, so risk of hepatocellular carcinoma goes on increasing. That's why we have to stop. Similarly, the studies clearly showed that if the patient is a smoker, you have to stop it. That will be helpful for the patient. So next, coming up, where is the population? Where we should treat and where we should not treat. We should treat if the patient has got NASH with fibrosis, advanced fibrosis, definitely if there is a cirrhosis. Don't treat if simple they have got the fatty liver, and also if give importance to the other factors like cardiovascular conditions and other comorbid conditions. We do not have any medication till now which is FDA approved. So that's why most of the drugs are off-label treatment. Then we have got the other important medications not approved for NASH, but may be helpful one, metformin, tauzolindians, rosiglitazone, pioglitazone. Then we have got the 5N studies published 2010, and they also clearly showed which was used, placebo, vitamin E, and the pioglitazone. 96 weeks treatment study that showed clearly that there is advantage of the pioglitazone as well as the vitamin E. Now coming to the vitamin E, there are so many studies, it is established today that it is very helpful one for NASH. Recent study, they are showing that if you use vitamin E alone or along with some other combination, definitely it is a helpful one. Then the question is, it improves NASH, that means vitamin E? Yes. It improves or fibrosis is, NASH is reversed? Yes. But the point is, whether it improves the fibrosis, till now, no, because it is not proved in other studies. Does it have a improved long-term outcome? Again, there is no RCJ trials to say about that one. So that's why it will take more time. Just give me 1 or 2 minutes. These are other medications which are helpful for controlling NASH. Of course, very interesting medication is GLP-1 and other medications which are obesity management medication, they are also helpful one. These are studies I am just showing with liraglutide, GLP-1 inhibitor, this is good. Semaglutide again is helpful one, the studies clearly show. Just coming to my own story. What is my story? In 2012, actually, Siemens company, they came to me, they installed one RP machine, that is the assessment of the liver fibrosis. In 2012, so on the last day, they told me to check the liver for yourself. We checked it, and they're showing clearly that I have got the liver fibrosis, early fibrosis. That time, my weight was not so high. I was diabetic, I was hypertensive, but well maintained. So next point, I checked the liver with ultrasound, next day itself. And it was showing the normal liver, no changes at all. So after 5 days, I was supposed to go to Singapore. I checked it with the Singapore General Hospital. They had the fibroscan machine those days. So they checked it and they told me that fibrosis is 18. That means clinically or histologically, I don't know. But otherwise, it is a early cirrhosis. It is 2012. So I follow it regularly for all these years. Coming to 2021, So my score is coming to 9.7. And cap value is also coming to 366. Again, sonography was showing normal liver. So then in 2023, this year, April, so it is coming down to 7.7 and 284 cap value. So again, I check the sonography normal. So my message here, first of all, why it is coming down? It is coming down most probably, I used to take coffee a lot, number one. Number two, lifestyle I have changed. The food habit I have changed for all these years. Vitamin E continuously I used to take. And liraglutide for probably 7 years continuously I am using liraglutide for diabetes. So here the message I am giving here, that though I had early cirrhosis, the study shows that 11% of the patients with everything normal, suppose, sonography normal, you may have serious fibrosis in those patients. So we have to take care of this point. Statin use is a controversial, but again, it can be used safely for NASH, but only for NASH, the treatment is not recommended till now. It is controversial one. Controlling obesity, we discussed about it, nothing to say. We have to go for endoscopic or bariatric surgery to reduce the fibrosis. Studies showing clearly it has got the effect. Then it is a multi-pathway system of treatment. The NASH resolution, fibrosis improvement, the reduction of the lipogenic fat, the weight loss, and the diabetic control. Together, you have to work, and then only we can get something in. Maybe there is a combination of need, but this should be something like this one so that we can get it. Coming to the end of my, on the slides, we need a hepatologist, of course, but we need a diabetologist. We need a nutrition expert. We need also the exercise expert. Then bariatric surgeons. Also, we need a primary care, possibly is a better one. In conclusion, it's a large population of the world today have got the NASH. No effective treatment we have got currently available. Try to manage comorbid conditions, and also weight reduction, lifestyle management are the primary thing in the management of non-alcoholic fatty liver disease. Love your liver to live longer. That is a message for you. With this, thank you all. And I request everyone to come to Guwahati for Northeast.
Thank you, sir, for your nice, elegant speech and share with us for your management strategy of MFLT, simply an FFLT. And thank you, sir, regarding the management strategy, initial management of acute pancreatitis of Dr. B.N. Sudhuri, sir. And thank you, Akeda, sir, for initial management, update management of alcoholic hepatitis. And now, time is very short, so we allowing the open discussion for 2 persons.
You tell that, yes, I do agree with you that acute pancreatitis is a sterile inflammatory process. Yes. So you tell that there is no need of giving prophylaxis antibiotics. But in settings like India or Assam, we do not have a good sterilizing process so that we can maintain it properly. So we are giving IV catheter and nasogastric tube as well as urinary catheter also. So with this, if a pancreatitis patient got infection, do you think that still we do not have to give prophylactic antibiotic? I will tell one story. I have a privilege to attend a breakfast session in national conference. So previous day, all the American and European people are telling that don't give prophylactic antibiotics. But in breakfast session, Dr. A.K. Asarja and Premises Korsar was also there. They were telling that in Indian scenario, you please give prophylactic antibiotic. So what is your view? And I ask this question to this gathering also.
Thank you, sir. It is a very pertinent question of this disease. In acute pancreatitis in initial period. So if we go the data to what is the present status of using antibiotic in acute pancreatitis without any evidence of infections. So in UK, it is used is around 80% of the patient. In worldwide, it varies from 30 to 90% of the acute pancreatitis initial period uses the antibiotic. In our Indian data, without evidence of acute pancreatitis, even in day 1 or day 2 started antibiotic around 66%. So what is the problem with using antibiotic in a acute pancreatitis? So first concern is development of gram-positive infection. Second concern is multi-drug resistant infections. And third concern is your fungal sepsis. So basically, if there is a necrosis, even in necrotic pancreatitis, it is inside the abdominal cavity. So, and this study shows for multiple RCTs, even meta-analysis goes in favor of not using prophylactic antibiotic. But there is a latest study, which in Japan, huge number of patients using antibiotic within 72 hours, using the procalcitonin base. That means those who are having high procalcitonin within 72 hours, they are using the antibiotic, and only benefit, which is a marginal benefit, using antibiotic, not as a prophylactic, using the procalcitonin as a marker. So only benefit shows there is a less extra pancreatic infections, as you rightly mentioned, Foley's catheterization, Ryle strip insertion, central line putting. So this type of infection is controlled by this antibiotic. Otherwise, study as per study or recommendation, there is no indication of antibiotic.
Any question we can be discussed with the speakers. Now we are waiting for a very nice oration by Dr. Das. So we conclude this session here. Thank you.
May I invite all the speakers of this session to be on stage for the photo session. Thank you so much. We will now have the prestigious Professor H.P. Borua oration. I request everyone to kindly gather inside the hall so that we can start the oration. So now we will start the proceedings of the prestigious Professor H.P. Barua oration. It's my pleasure. It's my pleasure to call upon stage the chairpersons for this oration, respected Dr. R.P. Medhi sir, Dr. N.K. Bhattacharjee sir, Dr. Sanjeev Kakoti sir, and Dr. Sarup Barua sir, to kindly chair the session. It's now with great pleasure that I invite on stage the orator for today, Professor Ashok Kumar Das sir, to kindly take his seat on the stage.
Hello. We are having the great privilege of organizing the H.P. Barua oration. He was a great physician. I had the opportunity to work under him. His secret was, success of his secret was his history taking and clinical methods. So we'll have our speaker. Yes. So next we'll have our oration of H.P. Barua.
So as we all know that this oration is held in every APICON Assam State Chapter Conference in honor of the late Professor H.P. Barua sir, who was one of the stalwarts in the field of medicine and a founder member of our dear API. We are indeed privileged for being able to pay respect to one of the father figures for all of us here. It's indeed a great pleasure. Thank you. Bhatta sir would like to say a few words.
Yeah. Good afternoon, everyone. I am making a little departure. Standing here instead of sitting on the dais. It is a privilege for me to present here today in this H.P. Barua Memorial Oration. It is because the old habits die hard, and Professor Barua was our teacher, my teacher, and from the student days, we always stand in front of a teacher, and I consider him, whether it's life or death, he's still a teacher for us. One of the greatest teachers and clinicians I know of. He was my guide, mentor, during my student days in GMC in mid-1960s, in the PG days, in the AMC in 1980s, and all throughout my career for the last 40 years or so in Dekargaon, Assam, till his death. Till his untimely and tragic death, I must say. Now, the life of a doctor is not measured by the years that he lived, but by the lives he has touched, by giving them cure, care, and the comfort. To the respect, the Professor Barua has lived his life full, I must say. because he will be in fond memories of everyone who came in contact with him in his even a short span of life. Innumerable lives he has touched, innumerable lives he has saved, and then he has given guidance to everyone. Now, today, while remembering him on his occasional commemoration, on behalf of everyone present here, pay our respect and reverence to him, because he will always guide and inspire us, whether in life and death. Thank you very much.
Thank you so much, sir. We now have the life sketch of the late Professor H.P. Barua, sir, which will be read out by Dr. Pritam Bhattakur.
Akhanda mandalakaram vyaptam yena sarasaram tatpadam darsitam yena tasmai Sri Guruve Namah. Tasmai Sri Guruve Namah. Dr. Hari Prasad Barua, my guru and mentor to many of us present here today. He was born in the year 1936 at Dibrugarh. 15th November was his birthday, and he did matriculation from Dekargaon Government Boys Higher Secondary School. This is my school also, so I can take pride in that. He passed from the school, and thereafter he did ISC from Cotton College, and he joined Assam Medical College. He was a very active student, very brilliant student. He stood first in a final MBBS examination. He was also the editor of MCOL during his student days, and he was also the president of AMC Students Union during that time. And thereafter he, for a brief period of time, joined as a registrar in Assam Medical College. Thereafter he went for his higher studies to London, and coming back from London, he joined Guwahati Medical College as an assistant professor of medicine. Then he rose to the position of professor of medicine and head of the Department of Medicine. In the year 1970, he married Ila Barua. Ila Barua retired as a professor in a government college in Guwahati, and now she resides at Guwahati. And Sir is a founder fellow of Indian Academy of Medical Specialties, and he thereafter rose to the position of principal and chief superintendent. He served both Assam Medical College and Guwahati Medical College in that capacity of principal and chief superintendent. And his association with API, he was the founder president of Association of Physicians of India, Assam chapter. Professor S.P. Barua, along with Professor Dulal Borkotuki, Hadia Lambora, Promotes Barua sir, they worked hard to form this Assam chapter of API, and he contributed immensely for the growth of Assam chapter of API. He also became the Dean Faculty of Medicine of Guwahati University and Dean Faculty of Medicine of Dekargaon University, and also chairman of IMA Academy of Medical Specialties of Assam State Branch. In an unfortunate incident, Sir died at the age of only 58 years on 24th of November at Dekargaon. His amiable disposition, his personality, the strength and confidence in his steps, his interaction with his students, and his numerous speeches he gave in various meetings inspired generations of medical students. Generations of medical students were inspired to pursue medicine and to work in this field with dignity, with morality, with honesty, and with pride. So that was his influence on his students. Just to give you an idea what type of impression he could make to his students, I would like to read out a tribute written by retired professor of Ohio University, professor of clinical medicine. He was a student of Professor Borua. See, he happened to see the photograph of Professor Borua in my Facebook account, and thereafter he wrote a tribute. I just want to read out that brief tribute. His name is Dr. Anil C. Thakuria. He is presently a citizen of USA. A man, my mentor, I revere till this day. I was his intern in medicine until at Jeeves. He understood me and always encouraged me to study in depth. He had in-depth knowledge about pathophysiology and basic sciences, which I connected well. I worked under many renowned physicians and scientists in India and abroad, and I could always single him out as one of the best mentors I ever had. At his encouragement, I went to PGI Chandigarh for a rigorous interview. I was one of the few, probably the youngest and a non-relative one, to ride with him in his car to Dekargaon on his wedding night. I was so honored. Soon after that, I was accepted at the PGI and I left with his blessings, and later I moved to the USA, and unfortunately in the struggle of my life, I lost contact with him. But never lost that respect and reverence, always thinking one day I shall get back to him. I hardly left an opportunity to mention about him to many of my colleagues when an opportunity arises. I knew he rose to the position of principal and chief superintendent of AMC, and I was very happy. Then suddenly one day I got the news of his life being cut short in a brutal act of violence in November of 1994. It shattered me and my life. By that time, I was a clinical assistant professor at the Ohio State University College of Medicine. I was deeply saddened, like many others did. It was too traumatic. I did not know you, Pritam, and I'm sure you do not know me either. In serendipity, I came across your name in a public awareness and health-related issue message that one of my friends shared. Appreciate your public service message. Keep up the good work. As I was impressed, I browsed through your profile and suddenly stopped seeing that unmistakable photograph and that reading your homage to one of my revered mentor, late Hari Prasad Borua, and saddened for a while. That unmistakable face with deep and bright eyes that exuded the rays of in-depth knowledge of clinical medicine and basic pathophysiology of disease. He taught us hematology like no one did in a relatively ill-equipped facility. Hope you forgive me for this borderline intrusion. Bless you. So this was the tribute written by one of his ex-students. API Assam chapter remembers Dr. Borua with great reverence and with love. Thank you so much.
Thank you so much, Pritamda, for the amazing words. We now have the felicitation of the orator. It's our deep and it's our honor that we are able to felicitate the orator, Professor Ashok Kumar Das. We'll be felicitating him, and may I request the entire organizing team to please come up on stage to felicitate the orator. I would like to request the organizing president, Dr. Atul Chandra Saikia, to kindly felicitate the orator with a hooray. I would like to invite Dr. Kartik Borkotaki, sir, to kindly felicitate the orator with a salang. I would like to request Dr. Anjali Goswami to kindly felicitate the orator with a bouquet. And I would like to request Dr. Bhavani Bhuya to kindly felicitate the orator with a japi. I would like to request everyone to please join in the japi. We have a citation for the orator, which will be read out by Professor Dejan Das.
Good afternoon to everyone. I'm reading out the citation. 32nd APICON Assam 2023 Tezpur. This is the 32nd Annual Conference of Association of Physicians of India, Assam State Chapter. Citation to Professor Ashok Kumar Das for our respected Professor H.P. Borua oration. It is with great reverence and admiration that we, API Assam State Chapter, are honored to bestow upon you the prestigious Professor Hari Prasad Borua oration on the occasion of 32nd APICON Assam 2023, held on 15 to 17 December 2023 at Greenwood Hotel, Dekargaon, Tezpur, Assam. Respected Sir, we are honored to have you amidst us in this annual conference of API Assam State Chapter held in Tezpur. Your illustrious stature as a doyen in the field of medicine, your profound wisdom, unwavering dedication, transformative influence has left an incredible mark on the medical landscape. Your oratory skills, academic achievements, nearing 200 national and international publications and resources have created a great impact on junior practitioners as well as many senior teachers. You being one of the father figures in the field of medicine and associations of physicians of India, who has adorned the chair of President of Associations of Physicians of India, as well as the Dean of Indian College of Physicians. No one else but you can be the right person to deliver this prestigious oration. We, the organizing committee of 32nd APICON Assam 2023, and all members of the API Assam State Chapter family would like to thank you for accepting our invitation to deliver this prestigious oration, sir. We wish you a happy and healthy life ahead. Yours sincerely, Dr. Utul Chandra Soikia, Organizing Chairperson from 32nd APICON Assam, Dr. Karthik Borkotoki, Chairman, Scientific Committee, Dr. Dejan Das, myself, Organizing Secretary, 32nd APICON Assam 2023, place Tezpur, Assam, dated 16 December 2023. So I'd like to hand over this citation to Sir.
Thank you so much. We now hand over to the chairpersons for conducting the session.
It is functioning. So it is our privilege to have among us Professor Ashok Kumar Das. We had a long association with Sir, as has been already introduced. He is a teacher of the teachers and has a very fond connection with Assam. And wherever we invite, he always accepts it. So without much delay, I request to go with the prestigious oration.
My honored, esteemed chairpersons, my dear, very honored organizing committee, dear Dvijanda, the President amidst us today, and I am speechless. I am overwhelmed by the love and the honor that you have bestowed on me. I come from Pondicherry, so there is a message that makes a little emotional. The message of the mother, Sri Aurobindo, Ashram mother said once, faith is the prize of victory. The only prize that this victory gives is the great faith in me that we are all on the right track. Thank you very much. I'm really speechless. But anyway, I have to do the job for which I'm here. Dear friends, I'm going to address a very fundamental issue next 25 minutes. I will not exceed at all my time, maybe less than 25 minutes. I'll finish in my watch before 1 o'clock. I think it is 12:30 now, 12:30. So by 12:55, it will be over, before that. Dear friends, I'm going to talk about something which was very close to the heart of Professor Hari Prasad Borua. Dear friends, my salutations to him, to the one who is living amongst the hearts of the students, to the one who had made a sea change in the medical education, and the one who as a principal sacrificed his life for whatever cause, and his blood in the soil of the Dekargaon or Assam, or the India for that matter, will make us richer, make us give more confidence, and we are all full of love and gratitude, reverence for this honest soul, Professor Hari Prasad Borua. Dear friends, on this occasion, I'll be talking about something, the transformative innovations, a medical clinical update. Dear friends, I'll be a little fast. Please relax. It's not a scientific talk. This is scientific talk, but it's a celebration. We're celebrating the sacrifice of our dear honored professor whose blood makes us feel that he's amongst us and makes us give richer and more thorough experience of what life is and what for we live. So it's a celebration. It's a life-changing innovation. So please just listen. So we will pass through what are the transforming innovations we have in the burden of the disease, paradigm shift, the shift in the oral drug, the insulin and the incretins, the atherosclerotic cardiovascular disease, part of diabetes mellitus, new drugs, new technology, will cover CGM to AI. But what is most important is the last sentence. Let us all adapt to these new innovations. And our patients, as Professor Borua has all along his life wished it, will wake up to these new possibilities enriched by these new innovations. Dear friends, the numbers of type 2 diabetes is alarming. You see today we have 101 million people diabetes and 136 million people with pre-diabetes. Together, this glycemia is 237 million. But what is most important, see the amount of hypertension, 385 million. General obesity, 254. Abdominal obesity, 353. Hypercholesterolemia, 213. And high LDL, 185. So this is what we called, when we wrote this paper in the Lancet on June the 7th, we called it the metabolic map of India. Dear friends, this is a grim picture of diabetes. You can see the red ones, which has a percentage of above 10%. And you can see the areas which has even 30%, 24%, Kerala, Pondicherry, Tripura, and parts of the country, almost 24-30%, the grim picture. Dear friends, but what is most important, the burden of uncontrolled diabetes. To make a long story short, we have between 16 to 23% diabetics who are controlled, rest are all uncontrolled. Therefore, when we did the study, I saw an in-depth study, and Sanjeev knows about the study, we wanted to screen 1,24,000 people. Dear friends, it has been held as the one study which is one of the largest ever study in diabetes mellitus. You can find the urban-rural divide, but again to draw attention, even though the diabetes was about only 9% in rural area, you find the pre-diabetes was 15.2, almost equal to the urban. And these pre-diabetics are waiting to become diabetic. Therefore, all NCDs were less in the rural areas than the urban, but pre-diabetes was almost similar or even little higher. Dear friends, if you look at the weighted prevalence of diabetes and pre-diabetes, this shows it is very widely prevalent in all the parts of the country. While diabetic epidemic is stabilizing in certain parts of the country, in southern India it is stabilizing. The pre-diabetes is still rising, and all the pre-diabetes waiting to become diabetic. Now, this is the weighted prevalence of hypertension, and I must tell you, we have a symposium hypertension I saw in the program. More than diabetes, hypertension is of paramount importance. Treating hypertension and diabetic is more important than treating blood glucose. And you know, the obesity is rampant, and also so much so the hypolipidemia, both triglyceridemia and hypercholesterolemia. So this is again metabolic map of India. So dear friends, from the lessons we learned from this study, and we have learned for the last 35 years, I'm going to present my talk on that. Dear friends, number one, today, the first transforming innovation, we know today type 2 diabetes as a cardio-renal metabolic disease, CRM disease, and pre-diabetes, or people don't call it pre-diabetes, gives sense of complacence, call it early diabetes, So early diabetes or full-blown diabetes are centered around glycemia, weight, they have equal amount of blood pressure rise and CV risk factors as diabetic. They have EGFR, low, albumin rising. So therefore, they are at the same platform as type 2 diabetes, or I will say advanced type 2 diabetes with hyperglycemia, IR, obesity, dyslipidemia, renal affection, and cardiac affection. Dear friends, there has been paradigm shift in the guideline. That is one of the transforming evidence of today's diabetes practice. We were glucocentric till 2015. 2016 we became CV and mortality benefits. 2018 we had the benefits in the atherosclerotic cardiovascular disease and the heart failure. In 2019 we have the advent of the GLP-1RA and SGLT2 inhibitors, and we became centered around cardiovascular disease and the kidney disease. In 2021 the guideline said that it is not only diabetes, but ACVD and CKD are more important. I will not dilate upon it because my esteemed colleague Jayant is going to speak about this paradigm shift. Dear friend, we wrote an article in JAPI, which you might have seen. We call it euthymia, the vascular euthymia of SGLT2. Euthymia means the benefit. And this is shown here. We have SGLT2I inhibitors, which have vascular hemodynamic benefits, from the blood pressure decrease to the decreased arterial stiffness to lot of vascular benefit. It has renal benefits, and it has cardiac benefits and metabolic benefits. Therefore, today, in today's paradigm, it has become one of the most important drug to deal with. Dear friends, we also have the GLP-1RA, which also has equally cardiometabolic effect of disease. And I was very much interested by seeing the presentation of Disha Hospital Chief when he said that one of the GLP-1RA has given a new life and freedom from the NASH. Dear friends, the clinical trial looking at the cardiovascular benefits of GLP-1RA, starting from the leader, which was centered around the drug which Professor was taking, the Victoza, or to Elixa, Susten 6, all the things have shown that there's a huge cardiovascular benefit of the GLP-1RA, be it injectable, like liraglutide, or be it oral, like semaglutide, which will come in a minute. Dear friends, it has been also shown that if you look at the steatohepatitis, the liver disease which has become numero and is responsible for the maximum onslaught and mortality, it is the steatotic liver disease. We call it MASLD today, and you will find that the steatotic liver disease, going to the various sub-classification, is centered around inflammation, centered around lipid accumulation. And the biomarker scores of the NFLD or MASLD and the FIB score, which is showed repeatedly, it has been shown and also shown in this year's June guideline of the ADA that the number one drug to treat NFLD today is GLP-1RA and SGLT inhibitors. Dear friends, I work for the DCGI. Today we have 9 GLP-1RAs and 5 SGLT inhibitors undergoing full-blown clinical trials, including liver biopsy. We have allowed liver biopsy twice to show the huge benefit of this group of drugs, GLP-1RA and SGLT inhibitors, on the NASH, which you saw some time back from the presentation. Therefore, today, the screening for the NFLD in type 2 diabetes mellitus in the ADA 233 standard of care is paramount importance, and it has clearly said ultrasound is not the one, you must go for the PIP scan. Dear friends, the SGLT2 inhibitor has a great hepatoprotective metabolic effect. And I have shown you very beautifully, I've taken the diagram from the author of this article, which said that the huge steatohepatic benefits of the SGLT2 must be taken home to everybody. It inhibits the AMPK activation. Metformin also does it, but it does it in the right trial manner, taking care of the various adipose tissue, the skeletal muscles, and it gives the real benefit in the NASH. Now, it has been shown in a 5-year follow-up study by Akuta, there's a very favorable effect of SGLT2 inhibitors in the NAFL, complicated with diabetes mellitus, in a 5-year follow-up study. And it may improve the outcome also in the patients who have cirrhosis in type 2 diabetes. I'm talking alcoholic cirrhosis, which my, again, esteemed colleague presented before him. Not an ordinary, but in type 2 diabetes cirrhosis, it has also a role to play. And also it has been shown that empagliflozin in particular, it is studied done by Amrish Mittal from Medanta Hospital, now in Max. It reduces liver fat content in individuals with type 2 diabetes with MASLD. It also reduces the liver fat content compared to DP4 inhibitors. And therefore, NAFLD, MASLD is common. Important comorbid type 2 diabetes mellitus, they do not die of liver failure, they die of the cardiovascular disease. Therefore, ultrasonography is not useful. I'm extremely happy Professor showed that. It is essential to screen high-risk patients, clinically significant fibrosis with non-invasive assessments like FIB4 index. Now, the next one is the link between the cardio-renal metabolic conditions. Dear friends, we have about 850 million people with the CKD. And today, the kidney disease has become of paramount importance. And you know, we have about 50% of the people diagnosed with heart failure, they die within within very 5 years of the diagnosis. The CKD is going higher. Today, prevalence is at least more than 11%. The 3/4 of the diabetic patients die of the heart disease. Therefore, the cardio-renal angle is of paramount importance. Dear friends, having one cardiovascular risk factor, renal or metabolic condition, increases the risk of having other risk factors of CVD, renal or metabolic aberration. Therefore, dear friends, this drug, namely this drug, the SGLT2 inhibitors and GLP-1 are stood in front as the real drug to be given to the diabetics, and these CV, renal and metabolic aberrations coexist together, and they, because they're interrelated, and therefore they have CKD, they have CVD, they have metabolic aberration, this drug of choice. Therefore, if you look at the CRM, there are plenty in type 2 diabetes, and early multifactorial intervention is the best way to help people protect by reducing, amplifying these factors. And therefore, this is the prevalence of the cardiovascular risk factors in the study population as per our India paper. And it's very important that we have to concentrate on this aspect of the paradigm shift in the management. Dear friends, I'll pass on to the patient-centric advances in insulin. I will not describe insulin from the Benting and Best. We have animal, NPH, we have what, but what is most important in insulin today that we have, I consider the best advance is the biosimilars. I'm very fond of biosimilars. I work for the government, and we use biosimilars left, right, and in the middle. And we call it, India, the land of biosimilars for the world. Land of biosimilar for the world. So I will not describe it further. 8 companies have brought in biosimilars, and 18 companies have filed application that bringing biosimilars. The price will be almost half. Coming to the newer insulin, which is very important today, which has made really transforming changes, is the rapid-acting insulin like the Lispro, very fast-acting Lispro, and of course the insulin, which the ultra-fast-acting bolus insulin. We also have the insulin, which has changed the scenario by being given as a mixture, be it a human mixture, be it analog mixture, or be it a co-formulation of insulin degludec with aspart. Dear friends, the future of insulin is very near. The oral insulin is knocking at the door. We are saying it will be back by 2025. We have the smart insulin. The smart insulins are such insulin which will appreciate or apprehend or know the amount of blood glucose in the insulin and will deliver that amount of insulin necessary for that degree of blood hypoglycemia. It's called smart insulin. This is called insulin-derived insulin dose. So therefore the blood glucose, the Oramed is knocking at the door, and it will be possibly, we have got the approval, Q3 approval in the 2024, another 2 years used to be here, rapid advances in the delivery system. Dear friend, there is a new insulin which has been approved by the Drug Control of India, but it will not hit the market till end next year. That is weekly insulin. I think it's a transforming advance, because instead of 365 injections, one has to take only 7 injections. And price, believe me, the company has promised will be exactly same or little less. And the injecting devices will be also less necessary, so it will be very affordable insulin. This Icotec insulin has to be given, if you're giving 10 units per day for 7 days, 70 per week, and then you add another 50% for the benefits, and there is no cholesterol insulin, and this has shown it does not predispose to hypoglycemia. In type 2 diabetes and various trials, it has shown that Icodec has stood the test of time, and it will be introduced middle next year or end next year. It is available, we have seen, we have done the drug trial, we have spoken about it. But what is most important is that we also have the drugs which are combination of this insulin with semaglutide. We call it CagriSema. I'll come to it in a minute, but now I'll pass on to the next advances, next transforming advances in the obesity. Now, about 20% of the world's population are obese, and it is threefold projected to grow in 2040, and 30% of the urban children have obese diabetic. I think Dr. Kakoti working on it. If you look at the global prevalence, 764 millions, and you know, worldwide the rates are increasing. The burden of obesity in India is very high. We have abdominal obesity in about 40% of the patients, and projected trends in the prevalence of obesity is also going to become very high, and we have general obesity in about 29% of the people. Now, what are the reality? Now, many people do not regard obesity as a disease. I don't know whether you should think obesity disease, medicalize it or not, but what is most important, one must take care of the obesity. Dear friends, there are anti-obesity medications which have changed the scenario of the obesity management. Now, pharmacotherapeutic principles and very efficient drugs like GLP-1 RAs are very efficient anti-obesity medications, and semaglutide, the oral GLP-1 RA, that's called protein in a pill, is the number one which has come to India. It came to India within 5 months of its introduction elsewhere in the world, and 2.4 milligrams is not yet available. Not injectable, not available, we have oral, and this has changed the scenario of obesity management. But there is a still better drug by some other company called tirzepatide, which is 39 amino acid synthetic peptide, which agonist activity with GIP, both GIP and GLP-1 receptors, and this reduces weight 3 times oral semaglutide. And the first and the only one GIP GLP receptor agonist is approved in type 2 diabetes. It will be coming to India in 3 months' time and will take the Indian drug pharmacy world by storm. If you look at the atherosclerotic cardiovascular disease, which is a very part and parcel of type 2 diabetes mellitus, the risk factor for ASCVD is ingrained in the obesity. So obesity management will become very important in managing the cardiovascular disease in the times to come. This obesity also responsible for the chronic kidney disease, and you will find these drugs are going to be very important. Now, ASCVD management must be prioritized early in type 2 diabetes management. That is the call given in the ADA ADA guideline. So, lifestyle, smoking intervention, lipid-lowering agents, antihypertensive agents, antithrombotic agents, anti-inflammatory agents, all have to be given. Now, I have shown here the amount of HbA1c reduction that can occur as a glycemic effect, anti-glycemic effect of these drugs. You can say it can be up to minus 1.3. The combination of semaglutide and SGLT2 inhibitors, the combination of SGLT2 semaglutide and GLP-1 RA semaglutide and SGLT2 also available, and you see the reduction in HbA1c can be double of what I have shown here. From 1.3, it will be minus 2.6. So it's a very effective anti-diabetes drug also. If you look at the weight reduction can be up to, oral can go up to 3.17 to 4 kg. And I would like to draw attention, even 5% weight loss, even 1 kg weight loss is very beneficial. This is with the drug which is taken at 3 milligram. If you take 7 and 14 milligram oral semaglutide, which are available in Belchers, the weight loss is still higher. Therefore, the future of incretin therapy is expanding. Now we have GLP-1 discovered in the country. It can be once daily, twice daily, once weekly that we have now. The semaglutide, the Vigobi, oral GLP-1 we have, the combined we have in 2022, and future is unraveling very much. Dear friend, this is the greatest discovery of mankind. Nobel Prize is expected to be given to the person who for the first time could give protein in a pill, and if this is successful, it will be equally successful for the oral insulin also. Dear friends, there are many side advantages of this oral semaglutide, protein in a pill. I will not go into details of it. Diabetes, CVD, obesity, non-alcoholic steatohepatitis, etc., even Alzheimer's disease, Parkinsonism. I want to end this topic by saying that obesity is at the heart of NCD epidemic. I've got last 7 minutes. You find whatever you call it, type 2 diabetes, osteoarthritis, PCOS, obstructive sleep apnea, hypertension, obesity is at it. And the obesity management has become very important. This is the weight reduction one. Now, I was talking about the combination therapy of CagriSema and tirzepatide, which will come next year, and there's a great transformative innovation to take care of glycemia and obesity. I'll know details of it. Now, beyond these drugs, there is also advances in the exercise. I'll show one thing that TLC, therapeutic lifestyle changes, has regressed the progress of diabetes mellitus in 58% cases in direct study in the diabetes prevention program. So therefore, my dear friends, we cannot neglect the advances in the exercise. We have said that exercise can rewrite the diabetes destiny, 58% reduction in type 2 diabetes mellitus. I'll go details of it. The carbohydrate count, the carb conundrum, don't give up the carbohydrate, but make it moderate. And it has shown that there is a U-shaped association, and the carb in moderation can also change the diabetes. And the third thing which has changed is patient empowerment. Therefore, self-management education for diabetic, we call it DMAC, is of paramount importance, and is also, I feel, one of the most important innovation in the diabetes management. Before I end, 2 things I'll say. One is very close to the heart of my friend Sanjeev. It's about the type 2 diabetes in the children or adolescents. When they're young and they're obese, believe me, in single sentence, they're more dangerous than type 1. So type 2 diabetes, sir, in the obese children, obese adolescents are very, very florid. They have all the complications. When diagnosed with 25 years of age, they have high mortality. Somebody wrote an editorial that we cannot see the funeral of our own children. That is the extent of problem. So the transformating innovation has been to recognize them. Once you recognize them, you have to put them on a very severe lifestyle, and also the drugs like SGLT2 inhibitor or GLP-1. And they have shown very, very gratifying changes in them. I will not go into details of it, but I'll just suffice to mention that this is a very important issue which has been taken care today. Now there's a study which is called MARK study, which has looked after the cardiovascular influence in these children and has suggested that SGLT2 inhibitors below 30 years, below 40 years, below 20 years of age, and shown this drug like SGLT2 inhibitor, GLP-1 and proper control of diabetes is of paramount importance. See, look at the type 2 diabetes in children, the high risk of complication. I've given all the complications here. Just see what is happening to them and why it is important. So what is new is from a 2-day follow-up study. And the new things it has said that one has to establish a very good lifestyle change plus the new drugs that are available today, because it has been also shown 1/3 of the young type 2 diabetics today have left ventricular diastolic dysfunction already in them. In our RSDI guideline also, we have accepted this, And as per the ADESD 22 guideline, we have also incorporated all this, and 23 meeting will be held shortly, which will find all these changes. Dear friend, I think the incretin-based therapy have been one of the great advances, new game changer for the management patients with diabetes, with CVD. And there is shifting pattern of management. We are going for the drugs which can take care of the kidneys and the heart and multiple other things. But having said that, the old drugs like metformin, sulfonylurea are also used plenty. And also they have found new, after this study like the Carolina study or Carbolina study, they have also found new leads of life. They are also cardioselective, cardiac benefit is ingrained in the sulfonylurea also. Today, the type 2 diabetes management, dear friends, is glucose-centric. Increase to put glucose in the time in range. You have to screen for the complication. It said, catch them young, catch them early. It is known today, if you catch the complication early, you can prevent them. Before the prodigal son goes beyond the time of no return, you can catch them early. And we have microalbuminuria, we have the leak from the eye vessels, we have got the vibration perception threshold between 10 and 15. We have tools to diagnose complications early, catch them young, catch them early. We have to give drugs to efficiently reduce the waste and the burden on the healthcare system, society, timely medication, and of course, we are for the 4A. The drugs must be available, must be affordable, must be accessible, and must be appropriate. Dear friends, before I end, I must convey my very sincere thanks and gratitude, and I'm very, very happy to say that this is one of my most important day, and I prize the love and the honor you have given me in my entire life. I will not forget it. I'll come back again and again. Thank you very much.
Thank you, Dr. Das, for a very informative and lucid presentation. You have shown us how a holistic approach to type 2 diabetes can change one's the other part of the diabetes like CVD risk, liver, kidney disease. Particularly, what it seems that semaglutide is a game changer, definitely. But still, you have emphasized on the importance of exercise, lifestyle management, which should go by apart from medication, side by side. Thank you again. As this is an oration, there will not be any question-answer session. If someone has any question, I can talk to him outside. Okay.
Before we disperse, let's have a group photograph with our learned speaker. Please, sir.
Thank you so much.
The honor was all ours, sir. I would like to thank our respected speaker and our respected chairpersons for conducting the session so beautifully. Moving ahead, next we have for you a mixed bag of topics. There will be a talk on how to write a scientific paper by Dr. Muhammad Jamil. There will be an approach to a case of dizziness by Dr. Numol Momin. And there will be a talk on the paradigm shift in diabetes care by Dr. Jayanta Panda sir, who has come all the way from Orissa to be with us. To chair the session, I would like to call upon the stage Dr. Sahid Ali sir, Dr. Debomoy Sanyal sir, Dr. Aditya Langthasa sir, Dr. Vishnu Deka sir, Dr. Prahanta Shonwal sir, and Dr. Chandana Sharma ma'am.